Morning everybody, a nice prompt start at 9:30. Welcome to our July meeting of the Integrated Care Board. Just so the board remember, this is live streamed, so other people will be watching us at our work this morning. I've got a few introductions to make and a few apologies to give. So in particular, we'd like to welcome Jonathan Coulter. Jonathan is known to everybody, I think, in the room, Chief Executive at Harrogate, and he's here on behalf of Jonathan Lofthouse and the Acute Collaborative this morning. We'd like to welcome Mike Farrer. Mike is a friend of this board, and in our early days he supported us in terms of the way we developed, and in particular Stephen and I. And I've invited Mike to come back today to review the board, see what we look like a year on, and to again give us some feedback on what he sees and hears and senses around being with us. And we welcome Sean Jones. Sean, where are you?
He's not.
He's not coming?
No.
Who is coming?
No.
You?
Yeah, Sean.
Okay. Great. So Sean Jones isn't coming, but we'll hear the performance update from Jane Hazelgrove.
Yeah.
Okay, lovely, thank you. I'd also like to welcome John Mitchell. John has been sitting in on our board meetings for the last few months in order to pursue a leadership development programme that he's undertaking. All of you are very welcome. Let me just give apologies while we're at it. We've got apologies from Michael Harrison, from Andrew Burnell, from Amanda Blur, from Jonathan Lofthouse, and from Simon Stockhill. And we've got some early departures today. Brent leaves us at 11:45 and Charlie is with us for the public board meeting this morning, but not this afternoon. So quite a lot of moving parts here today. Everyone who's here is more than welcome, however. I've had moving on with the agenda, I've had no declarations of interest from anybody this morning. Has that changed? No. We've done apologies, so that moves us directly to the minutes of our previous meeting. So let's have a look at those. I won't turn the pages, but I am going to ask you first, are there any points of accuracy in these minutes that anyone would like to raise? Emma?
Yeah, thank you, Chair. Just one point of clarity on page, I think it's page 6. Obviously, we talked about achievement of the financial position for the whole of the integrated care system. That was before we had sight of a technical issue at Harrogate. That obviously meant that the integrated care system actually ended the year with a 4.2 million deficit, but it was nationally agreed and technical in nature. But obviously Jonathan is here, so yeah, just wanted to say that.
Okay, do we need to do anything with the minutes to note that, or is
I think we should, yeah, I think we should just do a formal sort of post-meeting note.
So will you work with Karina to do?
I will do.
Okay,
yes.
Lovely. All right.
Thanks, Chair.
Thank you. Anything else in respect of accuracy in terms of these minutes? And I'm going to ask you for any matters arising that don't naturally appear on the agenda. Anything for anybody in terms of that? I had one. I did want to ask about the Resilience Hub, Jane. I think on page 7, we talked about the long-term sustainability of the Resilience Hub, but a review being undertaken, and the board sought assurance with respect to alternatives in the event that the ongoing operation of the hub was not viable. Have we come to a conclusion about this?
We're about there for a conclusion with an announcement imminent, yes.
Okay. Nothing that we can share today?
No.
Okay. Anything else that anybody has to raise in terms of a matter from those minutes? Okay, thank you very much. Let's then move on to the actions from our previous meeting. There's a number of things to follow up on, but I think most of them are completed. So there's some actions around voice of lived experience, further engagement focus to be given to the 13 to 18-year-old population. We have from Anya that that's completed and closed, or rather has been incorporated into the ongoing plan. That future reports would include primary care data in relation to the friend and family test where available, And it says here action for future board reports. So that will be incorporated in future board reports.
Yeah, so we're, as you can see, we've massively redrafted the performance reports. So when I come onto that agenda item, we can talk about the progress and what the next steps are.
Okay.
Definitely, we will be including those.
That's lovely, Jane. Thank you. And ICB data from the NHS 111 engagement will be supplied to Yorkshire Ambulance Service. And again, I think, Anya, you're saying this is has a revised completion date. Do you want to just update us there?
Yes, it was just the further in-depth work around 111 was postponed due to the pre-election period. So that has now recommenced. So absolutely that action will be completed once the full report is then completed. And I think we've suggested October for the final point.
Okay, lovely, thank you. A further action was submitting a written response to the NHS Constitution consultation. And I'm thinking, Karina, that we've done that, haven't we?
Yeah, there's an item on the agenda just for the board to know.
Thank you. And an update on community diagnostic centres, which we received in June, Jane.
Yeah.
And I think there's a little bit more about that in here as well, isn't there?
It went in, and as part of their diagnostic update, yes.
Okay, lovely. Then, as we move on, a report on suicide rates in North Lincolnshire will be brought to the board, and that will be part of the August agenda, Teresa, is that right?
That's right.
Scheduling of integrated impact assessment consideration for ambulance services interface with the wider system, part of a board deep dive programme, and that's completed and closed, but we'll be looking at that to some extent today, is that correct?
Yes.
Thank you, Teresa. Primary care access recovery plan, primary care case highlighted by local authority partner member to be followed up outside this meeting. That has Mike Napier's name against it, and that's marked as complete. I'm afraid I don't know the detail around that. Do you, Karina?
So I know that the conversation was picked up outside of the meeting, and the actual case has been dealt with, and all the arrangements have been put in place.
Okay, so we're happy that's closed. The annual ICB annual report to include reference to 23-24 capital developments and 23-24 primary care access delivery. Again, Karina, that's done. And finally, in respect of the BAF, there were some updates required there. And as Jane said, when we come to the BAF and we come to our performance reporting, the board will see that there's been quite a lot of work going on around both of those things to attempt to improve ease of access to that information and help the board better in its thinking and decision making. So those are the actions, all of which are completed, or we know when they're going to be complete. Let me just ask, are there any matters of any other business that anybody wants to raise? No, very good. Just before we get into the BAF, I thought it would be, you might all be delighted to find a copy of the annual report in your place. I'm so pleased and proud of this document. We're a relatively young organisation with a hugely complex agenda to follow. And this document felt to me mature, it felt positive, and it felt bright. So I think all of us can use this when we're on our travels in terms of those we meet to describe an organisation that's really starting to find itself and find a way forward. So I'm delighted it's here. Obviously, I'm delighted I've got a hard version. Most of you probably love seeing on your laptops, don't you? But I like having a book. And with that also goes our integrated strategy. This is a strategy we've been talking about for some time. And again, you've got a hard copy of that. Quite useful reference sometimes, I think, a document like this, certainly for me, when I'm out and about. So two important documents for board members today. And there's extras of those if you want to take them back into your organisations, for example, or into your teams. I think we should be sharing these as widely as we possibly can. I think thanks go to all the teams. I expect it's been a very big effort from everyone to pull these documents together. So grateful for that. Thank you. Right. Seem to be offered to gallop this morning, don't I? I think that's because I know we've got a lot to cover. So let's just go to item 7, which is the board assurance framework. A document which we're ever seeking to improve, ever seeking to clarify, and ever seeking to make an even more useful tool for the board in terms of the way it thinks about risk. And I think I'm going to hand over to you, Karina.
Yes, thank you, Chair. So, based on the feedback from the board last time, we've attempted to simplify and reduce the number of tables and information that was just using numbers that meant people were having to cross-reference a lot of detail. So hopefully people will welcome that, so it's a little bit clearer for everybody. I think broadly the key thing to draw the board's attention to in relation to the bath, specifically this month, is in relation to the mitigating actions. We have said that one of the things that the board wants to do and consider is to make sure that we feel we have further assurance for mitigating actions, particularly in relation to quality, finance, performance and workforce. So that whole, it's not even a triangulation now, is it? It's a quad, whatever quad version of that is. To be assessed as part of the board's ongoing consideration of high-risk elements to the delivery of our operational and financial plans. So the first of these subjects is on the agenda for today, so we are talking about urgent and emergency care later on the agenda. So at the end of the meeting we may want to consider whether we feel that that provides the assurance in relation to where we are with the board assurance framework. So that's the key thing. All of the risks have been reviewed this month, but there's no real things to bring to the board's attention.
Okay. Any comments about the board assurance framework at this stage? Yes, Charlie.
Can I make a comment? It may be premature, but worth thinking about nonetheless, around C3 finance. Because it's basically what it was last year. And something changed last week. And we are beginning to see, in very rough outline at the moment, some changes of direction. West Streeting's talked about rebalancing from acute to chronic.
Yeah.
And I'm just wondering whether this risk is articulated in an old way and may need to change in order to adapt to the different kinds of financial challenge that the new government may give the NHS. It's a bit Groundhog Day at the moment. Does it need to be a bit more forward-looking, anticipating where the government is likely to be trying to nudge the NHS?
Thank you, Charlie. Stephen.
Yeah, thank you, Charlie. It's an important point. I think the way we might think about framing that is, not to do the detail here, is our resolve from the time out we had earlier in the year, where we talked about two things, actually. We talked about spending a percentage between 5 and 10% very firmly in that direction around prevention and what you might broadly describe as out-of-hospital care. And the other element, which we may have captured, is about this creating surplus in order for us to do that. So I'm agreeing very much with what you're saying, and maybe that's what we should do. I mean, in a sense, it sits under the outcome-led resourcing box on here, doesn't it, C3? But I think to elaborate in that way would be important. I don't think we've actually settled quite very on that percentage based on the financial analysis, but we would be looking at that over a 3 to 5 year period.
Thank you, Stephen. Stan.
Thank you very much. Councillor Stan Shreve. A specific comment and then a couple of general comments. I have to agree with Charlie that this risk that he's referred to in particular does need reframing, I think, and restating. So that's my specific comment. My general comment is it's good to see the positive movement on a number of these risks, and it's also good to see, in general terms, the way that the report is now presented, because it's much more accessible, much more readable, and I think we have to compliment the team in producing what is a very, very good document. There are a number of other risks that where we may want to consider the appetite again, as the year progresses, but I'm sure we could schedule that into future board meetings.
Yeah, thank you, Stan. Any other comments? I accept what you're saying. It's something about how able are we to change as the times move around us. This C3 is quite a practical thing about have we got our resources in the right place, and can we live within those resources? So it might be that what you're describing is a new risk. I wonder. Anyway, we'll take that away from the board, but I think you're right, because there will be something about those people who can get off the blocks quickly and move with change and respond to change well, and we need to be in a system that can do that, don't we? So I think maybe they're different, but we'll leave that to you. Any further comments relating to the BAF? And Karina, just to check, can we have a version of that then for next month in the BAF? Can it be ready for August?
We can look to.
Lovely, lovely, thank you. Okay, for those people who are observing our board meeting, we do this review of the risks associated with the achievement of our overall objectives, always at the start of the board meeting and always at the end of the board meeting, because we want to be sure that the things we talk about, the things that preoccupy us, are the things that demonstrate the greatest risk to the achievement of our overall objectives. So thank you for that. Let's move on now, please, to item number 8.
So I'm delighted to be here today to launch a Centre of Excellence across our region in Humber and North Yorkshire, stretching from Harrogate all the way down to North Lincolnshire. I'm here at the Jean Bishop Integrated Care Centre, and we're building our Centre of Excellence on the back of 6 years of really hard, innovative, dynamic work.
Our health is about a lot of things: where we happen to be born, what our education happens to be like, how good our parents manage to be. All these things impact our health. And there's recognition that those things don't all fall within the remit of the NHS. So how do we enable babies and children to start well in their lives? How do we then go on and live well during the course of our lives? What can we do to make sure that the ageing process enables us to live well and independently? How do we ensure that when end of life comes, it's the best death that can be managed? Again, potentially closer to home, with care that's wrapped around you at home rather than you finding yourself in a hospital. We're also concerned about the difference in healthy life expectancy. So in more deprived areas, we see people become more frail and begin to suffer with ill health in their mid-50s, where in a more prosperous area that process might not begin till somewhat in their 70s. And one of the absolute objectives of our integrated care system is to balance that out, and those are our ambitions, that we level out this difference in life expectancy and we level out this difference in healthy life expectancy.
So it's all around identifying people living with frailty, knowing what their wishes are, which generally is around independence and well-being, but really understanding, our needs of our frail population and how we can support them better.
It's about how we join all this up as a system, not automatically send everybody to hospital. We've got the evidence base to say it's not just the right thing to do economically, but from a patient perspective and their family's perspective as well.
But what we really want to be as a system is in a place where we're expanding those healthy life years of an individual as they age, so their time spent living with severe frailty is decreased, but their healthy time is increased.
So this model of anticipating illness before it happens, preventing illness, caring for people in a way that enables them to stay at home is absolutely the preferable way.
I'm used to doing everything myself, but things have got more difficult now. It takes longer and it gets more difficult to do things, you name it, I've got it.
Somebody might, have a fall. We can look at, how can we try and prevent future falls, but also support them still to potentially stay at home if that's what they want, or have short periods of rehabilitation again, but trying to support them getting back to being as independent and well as possible.
But he is getting to the point where we just need a little bit more help. So that's why we've accessed the Jean Bishop Centre to keep him in his own home, really, for as long as we possibly can. his mobility is getting progressively worse. They've given him a frame with skis on and all that sort of stuff and everything. They've just been absolutely fabulous.
What's really heartening, I think, is that everybody seems to have left their organisational hat at the door, and they're coming together to do this because it's the right thing to do.
We're actually just one team working together, providing that seamless care for patients with frailty through both anticipatory care, crisis response, and getting them out of hospital. And then what do we need to do to wrap services around them once they come out of hospital to try and prevent them from going back in again?
So it's taking all the ideas, innovations that are working in these different places to improve outcomes and improve the care of people with frailty, bringing those leads together to be able to understand what's working well, what could we do differently, how can we learn from one another, share that best practice and ultimately improve outcomes.
If you have frailty and you live with frailty, we can offer the same response irrespective of where you live across the board.
They get to see one doctor who understands and knows their case, who can manage all the elements of their condition. So it's a really, really efficient way of treating patients, but it's also much more user-friendly. So much easier to come to one place and have all your needs met than find yourself with multiple appointments going to different places.
It's good, yeah. I'll give them top marks for that. They've sort of got charm for you, you know. And they don't choke over you like a lot of medical people do with long words and things. They say it as it is, you know.
The communication between themselves and me is absolutely amazing. They're just, top notch. Can't fault it.
Everything these people have promised, they've done. You know, so can't fault them.
It's a bit moving, actually, watching that, isn't it? We've all known, haven't we, that the Jean Bishop Centre is an incredibly important part of what we do and a really extraordinary model of care in a community. And it was Stephen's exasperation, really, that said, if this is so good, why aren't we doing it everywhere? And I think that's where you began to start talking about this becoming a centre of excellence, Stephen. And I don't know if you want to say a little bit more.
Well, no, not a great deal. I mean, I think there's some key ingredients there that I emphasised, really. I think, first of all, as in the film, there's a lot of learning in that from the patients themselves, the people in the community. Secondly, this is a model we're trying to follow in our other centres of excellence. It's entirely clinically led, as you probably heard in the film, with a very clear vision which fits with the clear notion of patients wherever possible being treated away from hospital setting, particularly the elderly frail in this case. And then just to emphasise what you said, really, I mean, the Jean Bishop Centre has got an international and national reputation, so I think it's actually a duty of this board and all the partners within it to make that model happen for all of our population, the elderly frail population, which of course is growing significantly, as we know from previous presentations here, to benefit from that approach. And I might say it fits very much with the emphasis that the new government's placing on health. Thanks.
Emma.
Yeah, if I can, thank you, Chair. Just following that and really connecting it back to the conversation we were just having around the BAF risk in C3.
Yes.
This is exactly the type of service that we need to be putting our resources behind, absolutely, in the medium and long term. And I think just to say as well, the success of the service isn't about the building, it's about using the workforce fundamentally differently and existing workforce. So it's not about necessarily additional investment all the time, and it's about how we organise ourselves and work across organisational boundaries ultimately.
That's a really, really good point, Emma. Brent?
Yeah, I was just building on Emma's point, really. I think what's clear about that service is it starts with the vision, the ethos and the way of working, doesn't it, between the professionals. Clearly they mentioned, obviously, there were different organisations working under one roof. providing that seamless service, and that leads to a better experience and outcome. When I'm thinking about our operating model and your challenge, Stephen, around how do we scale this, thinking about the potential and the collaboratives.
Yeah.
To work on something like this, obviously it's a cross collaborative initiative, really, isn't it? There will be a number of different aspects from some of the community or acute or your mental health that we'll need to be thinking about how do we knit together then with the place work that Pete's been leading on, which I think is something that we can probably sort of look at and think about how do we make some sense of what's happened here, and then think about how do we scale it. So there's a challenge there. And the other thing, just linking it to the performance report later, we were talking about dementia diagnostic rates. There's something we can add in there actually.
Yes.
And something even better still that we can look at that they can do there.
Thank you, Brent. Stephen?
Well, just building on that, that's a very good point. I just to say that the community collaborative has got the lead to carry forward what you're describing, but just emphasise your point. This is about, and I think just to reassure the board, I think we're making quite good progress on the collaborative leaders across our 5 collaboratives coming together precisely, because obviously it cuts across all areas, including, let's not forget, the voluntary sector and the community service collaborative, and indeed the mental health collaborative. Strong links with our partners, particularly in local government, are a big part of all of this. So that's critical it's mission critical, really, that those collaboratives come together under the leadership of one, working as a team to make that happen.
Thanks, Stephen. Nigel and then Stan.
Yeah, I completely agree with everything. What a note of caution for me would be that this shouldn't be without rebuilding general practice as well, because a lot of the things that this does can be done by general practice if it's resourced and sourced properly. And then the Centre of Excellence can be for the really, really difficult frail that would tip into hospital and become really hard for those to come back home. I was very fortunate that colleagues around the table joined us at a time out at my practice last week, and one of the things that one of my partners talked about was continuity of care. And continuity of care in any area absolutely saves lives, reduces mortality, deprescribing rates, everything like that. So this goes alongside, in my view, us rebuilding community and primary care services, just as Stan was talking about.
Yeah, thank you, Nigel. Stan?
A couple of points. Stephen alluded to one of the points I was going to make, which is we mustn't underestimate the importance of the voluntary sector in all of this, because much of the support delivered to our residents is delivered by the voluntary sector.
Yes.
Formal and informal. And it's really important that we find some way of plotting those in to the more general work. And the second point is every one of the 6 places within its local authority budgets has this thing called the Disabled Facilities Grant,
right,
which is administered by local authorities, but is a really important matter when it comes to management of frailty, because it's all about putting wet rooms in for people, handrails, stair lifts, all of those sorts of things that enable people to continue to live independently in their homes. And it's not means tested, it's needs tested, and it's really, really important. In North East Lincolnshire, horrifically, we're having a problem spending it because we don't have enough demand on it, which to me is an absolutely astonishing thing, really.
Wow.
And I'm forever pushing it, as I am doing this morning. So I've made the point. I won't labour it.
Thanks, Stan. That's interesting. I'm going to just give you an order now. We're going to go Jonathan, Charlie, Teresa, Jane, Louise. You've got to remember which order you're in, because I can't. Jonathan Stars.
Thanks, Chair. It's just building a little bit on what Stan said. I think that was a really powerful video, but I think the audience that's missing it at the moment is probably the social care audience that ought to be aware of it.
Yes.
And I think that's something, not maybe for this board, but certainly a place in the ICP. Because I think often now I sit around this board alongside Stan, and we're a small voice, but not a strong voice for the social care side, which is really important.
Good
That's
point.
Building on a debate we had internally yesterday between our public health team and adult social care team about prevention. And And the people that weren't round the table were the NHS there. And I said, well, because of the life prevention agenda,
Right.
huge debate. And I just think we need to think about how we build some of these
Yes.
into that social care
Yeah, and yeah, I'm sure
system so they feel part of it. Particularly, as Stephen said, this is a clinically led project.
yeah.
And again, it sort of almost distances by saying that from the social care aspect, which is so important in following up a lot of this work that's being done. So I think it's something we just need to think about.
You're absolutely right, Jonathan. Yeah, you're right. Charlie, I think.
Connectedly, I think. Stephen, is there a cost-benefit analysis available for this centre? Because the 88-year-old man is receiving services that keep him in his home, as his daughter said, which is a darn sight cheaper than the other alternatives. And if we want to scale, there's a really obvious way. This is going to save NHS money. It's going to save social care provision. So, is there some hard financial data around this which could help to make that case for scaling?
Steve?
Yes, on a small scale. So we need to get that whole picture. And I would just add to that the issue, if we think about set that in the context of that time bomb, really, of the elderly frail that we've heard about. We need to, and the deployment of resources as a result, and the benefits that might accrue. That's going to give us some choices to make about where we deploy those resources based on the numbers and the concentration. So the short answer is we have evidence on, but not at the scale we needed, which I'm no doubt we will bring back Emma. In some shape or form. And I think it's an important principle, actually, in all of these big programmes that we're, there are other centres of excellence that we're developing in the same and have in place in the same sort of context.
Teresa.
Thank you. So we've said it's clinically led, and that's right. But for me, the biggest takeaway from that film is fundamentally the organising principle is the patient, and the services are around the patient, rather than the patient having to navigate.
Yes.
I think that's the biggest takeaway.
Yeah. And we know that that's a really complex thing to do when you're frail and elderly, if you've got a whole string of different appointments in different locations, isn't it? Jane?
Yeah, thank you. Jonathan, just on your point, my mum's in a care home. She's just been referred to the Jean Bishop Centre for the Frailty, so the social worker was aware of and linked to that, so I thought you might quite like that feedback. Mine was really around the workforce. So what you've got in the Jean Bishop Centre is a workforce that are completely in control, aren't they, of that environment, what they're creating for that patient. We don't have Dan Harmon's all over our patch, I don't think, and he's got a lifetime of experience around looking after elderly and frail, and has made life choices on the back of it. Building that is absolutely critical to us to be able to spread, and having the workforce available to be able to do it. Otherwise, it falls short, doesn't it?
Yeah, and that again is about priorities and how we choose to use our resources. Louise, I think yours is the final comment.
Yes, thank you, and not to forget carers. And how we make sure that this centre and other centres interface and work with carers. And we've got some fantastic carers organisations, and some people might not think of themselves as carers, but how we support carers is critical to making sure people have the lives that they want to live.
Yeah, good point, Louise. I suppose for my final question, Anya, is how are we going to use this film? Where is it going? Who is going to see it? Is there a plan?
Yes, there is a plan, and the plan starts today with a media release of the intent of the Centre for Excellence. Today, that media release of the film will be going out.
Okay. Okay. Did you want to say something, Peter?
May I?
Yes, you may.
I suppose drawing all of that conversation together boils down to two things. If we're to meet a population of need, we have to be person-centred and outcomes-focused.
Yeah.
Whether that's looking through the lens of finances or Nigel's challenge around how people access. Is it a building, or is it about how you get your needs met? So I suppose there's something as we develop out our thinking of how we keep sighted on how deep is that person-centred, outcome-led approach in all parts of the system. So I don't think we can solve it here, and I don't think it's something we account for. We can account for the money. Accounting for the culture of practice might be a more challenging thing that through collaboratives and places we might need to pick up on.
Thank you. Thank you. Item 8 is also service user, patient, population focused item. This is with you, Anya, and this is our Voice of Lived Experience report.
Yes, thank you, Chair. There are two key items on this. The first being the most substantive item, and that is some work that was undertaken on behalf of YAS through Healthwatch, particularly focused in the Hull and wider East Riding area, focusing on the experiences of the ambulance service from our homeless community. And firstly, I would just like to say how important this work is. We know that our inclusion groups are groups that face some of the biggest health inequalities and issues in terms of accessing services, so it's really great from an inclusivity perspective to see this work being done around that important group. And it goes without saying that that group also are some of the most vulnerable people within our community. So it is really important that this sensitive work has been done to understand their experiences. I'm not going to go through the slides because what I would like to do is just share a snippet of the film, which really gives directly the voice of the lived experience. But I just did want to pull out a few aspects of the findings. And some of it probably won't be surprising, but there were a number of physical barriers experienced by members of our homeless community in accessing an ambulance, and that is an obvious one around lack of phone access. How do you access an ambulance if you don't have easy access to a phone? The general chaotic lifestyles experienced by members of this community. A lack of knowledge around other services, particularly patient transport and 111. Many people in this community have substance dependence, which may again impact their decision making, etc. And in parts of our homeless community there are strong networks, friendships, attachments that are made, and sometimes a person that's in need of help may fear actually leaving other people for whom they're dependent on. So there were just some of the physical barriers, and then there are a number of emotional barriers. And again, if you have spent time or can make the time to view the whole video, I think it really brings to life some of this, that there's a very, very strong feeling from members of this community around the fear of being judged. This is something that many of them have experienced their entire life, and it can't be underestimated, you know, the significance of that fear. For many of them, unfortunately, health is just not a priority in terms of their world. And again, linked to what I said at the start, trauma is very apparent with this group of people in our community, and therefore it exacerbates this fear of clinical environments, and particularly a fear of ED. So there are instances where, you know, the individual or the people around them know that they need medical attention, but that fear negates, if you like, or overrides the need to access that. So I just did want to pull out those points. But if I may, I'm just going to go to the video. We're not going to play the whole video, but if colleagues haven't seen it, please do. But there is just a snippet from a member of the community that I think is just important to hear around a very positive experience that they had in using our ambulance service.
I was homeless for about 4 months. That led to having one too many drinks. One of my support workers came for a home visit. I was just sprawled out on the floor, not responding to anything. Rang up the ambulance. The 2 guys came through, asked me loads of questions, but there wasn't. They were good about it. Do you know what I mean? They weren't like saying, "Oh, he's drunk. We just forget it." I don't suppose I would have been where I am now if it wasn't for these guys coming and treating me just like a normal person. you know you've done something wrong. But these guys, they're not there to judge you. They're there to help you, regardless of the situation. Me personally, I know they're there to help. Not to be judgmental. Not to think that they're better than you. Everybody gets treated the same.
Stop there. I just wanted to share that because I think it's just such a powerful piece, but please do take time to see. It's about 10 minutes long, the whole film. You can see on the further slides the recommendations and actions, and particularly that Yaz are leading on, but again, a really, really important piece of work that's been undertaken there. I'm just conscious of time, so if I can just move on, please, a couple of slides. I did just want to share, which I think is particularly pertinent. Sorry, if we can move on again, please. Yes, it's this one. So I did just want to share, and the Chair thought it was helpful as well. In the run-up to the election, there was obviously a lot of work in terms of understanding the views of the public on various issues, but there was some particular work that was commissioned through Ipsos for the Health Foundation, particularly focusing on the public's view of the NHS. This included general, deliberative and polling research, and I did just want to share the key points with you because I think it's very relevant to our agenda moving forward, particularly in this new dawn that we are now in. Some of it you will already be familiar with because it echoes some of the other public opinion surveys in relation to the NHS. The first key point that we are all aware of is that at present the public is largely dissatisfied with how the NHS is working and is very concerned about its future. However, the public maintains a very deep appreciation for our health service and its founding principles. That does not waver at all. And there's a general understanding that there are a wide range of factors that lead to the current strain, but particularly in the public's mind, workforce is a top priority. The public wants primary and community care to be a higher priority for the NHS, which links back, I think, Charlie, to the point you made earlier, above hospital services. And while participants, particularly in the deliberative research, would not accept a decline in access to hospital care for those that need it, there was support for a steady rebalancing of that funding over time. And very interestingly, in the deliberative research, most of the people involved in that actually would be willing to pay more through additional taxes to achieve better levels of service, which was very interesting. The caveat being that, of course, those that couldn't afford to pay if something like that did happen should be protected, but there was a willingness to actually contribute more, again going back to maintaining the founding principles of the NHS. And yeah, those are the main points really. I thought that was really helpful to share, and again there's the link to the full report if anybody would like to read further. So thank you, Chair, that was it from me.
You're welcome, thank you. Any comments around you? Jason and Mark.
So appreciate time, but I want to go back to the Yaz report because I think it is really significant, I think, for this board, and I think it kind of chimes with, I think, what Stephen's talked about, what we've talked about thinking about the needs of people and then services being designed around people rather than expecting people to kind of shoehorn in. So it's worth saying that piece of work that Healthwatch have done, which I think is exemplary, and I think, you know, we kind of need to appreciate a really tricky group of people to work with, a really powerful report, and if you read the final report when it's published, there are some really, really emotive stories about what it's like for people trying to access services that we all provide. So when that's published, it's got some real national kind of like traction with it. It was presented at Confed, so I think it's a piece of work we need to be proud of as a board, and I think, appreciate time, but a couple of slides probably don't do it justice. I know this is a report which is about Hull and which is about ambulances, but it isn't. What it's about is around a group of people trying to access services at the time where they need them and our inability to provide services in the way that meet their needs. And I think I'd quite like as a board not to kind of just kind of look at the slides. There are some really powerful recommendations about mental health. There's some really powerful recommendations about staff training. There's some really powerful recommendations around dual diagnosis and around what comes first. And actually, for all parts of our system, the test for me is, with this group of people who are going through multiple kind of conditions, multiple difficulties, finding a front door, any door, is proving to be impossible, that the only port of call they have is to dial an ambulance and to turn up at a hospital. So thinking about the principles of which this board was kind of set up, which was about integration, which was around how do we deliver services differently, I suppose the challenge is to say, what does this mean for all of our services? How does this fit with our vision? So the centre of excellence stuff. But also, if we were to apply this in all of our 6 places, actually how assured are we that this isn't going to happen in North Yorkshire, North East Lincolnshire? How do we coordinate the money that sits in local authorities around homelessness and the money that sits in health? And actually, what's our appetite for thinking and working differently? How do we really embrace what actually is real collaborative working? Because actually it's all of the collaboratives. It goes back to the whole bit. You know, the voluntary sector provides so much services here. But also, how do we challenge ourselves that this is one particular inclusion group? If we had the same conversation around sex workers, we had the same conversation about other people, I think also my challenge back to the board and my challenge to myself is there is some real positivity in those stories. There's an awful lot of negativity. There are a series of recommendations that somebody somewhere will need to make sure happens. And I kind of feel the moral conscience of the board is to say, it's quite uncomfortable to read some of this stuff. So actually, what are we going to do differently? And I think that's why we're here. So I think it's a really important report, and I appreciate time. But when that comes out, Anya, I think people need to read it. I would probably like to revisit that when Health Watch return to the board.
Okay, lovely, thank you. And we'll take that as an action. Jason, thank you. Mark?
Yeah, just a quick point. So I think the Health Foundation survey, the snapshot of the public's views that Anya's just talked about, is really important in terms of what it's saying to us. And I think we should note the fact that there's some of the things that are in there which really underpin the direction that we as an ICB are going in and need to go in. So I think that's my first point. My second is a question. So Anya, I think this is really important, and I think we should return to this kind of thing. So do we know whether this will be repeated at some point, or there will be a similar sort of survey that we can return to?
Yes. So there are fairly regular surveys, should I say, and there's also the National Opinion Survey that happens on an annual basis as well. So yes, absolutely. Because if board colleagues recall, we did something not dissimilar actually at a Humber and North Yorkshire level last year when the NHS celebrated 75 years. So there is a lot of insight, and it's something that we can continue to report on. Yes.
Jonathan.
Just really quickly. I think sometimes we overcomplicate things. Because I think for 76 years, I think the population have said high quality services when they can access it with good staff in good environments, and I think the Health Foundation probably confirms what we know. It doesn't make it any easier to do because even internally we provide preventative services in our organisation. We provide community services and hospital services, and we're desperately trying inside one small organisation to move resources around is really, really challenging. So I think the test of us as a board is how we're practically going to make that happen, because I think we know the theory, we know what the population would like and the left shift, and we talk about that, but how do we actually do that, and how do we as a ICB set some principles and hold ourselves to account for doing it? Because I think we know this, don't we, in our minds, but then when we leave here we forget that and get into how we've always done things. That's probably back to the forward view of our risks and our BAF. That's the challenge that we've got, and as I say, it's not overcomplicated, but it doesn't make it easy to do.
Yeah, my sense with that always is who's the management guru who talks about stepping out of his house every day, and every day he goes and leads against an enormous boulder, and every day the boulder doesn't move, and he does it for days and weeks and years, and then one day it incrementally does move, and once it starts to move it becomes an unstoppable force. And I feel that we're still leaning on that boulder, but I think there is incremental movement, and I do think that once we start moving in this direction, it'll be so plainly the right thing to do, that we'll gain traction, unimaginable traction. The thing I liked about that report is it indicates that the public at large get it. They understand and know that the shape of health services needs to change. I took that as really encouraging. Stan, I think you wanted to contribute.
Yeah, just echoing what you did say. I have a slight qualification on this report, and I will read the detail, but
the first or the
make
second
such
one, Stan?
absolute statements of fact. I'd be interested to know the sample size, on the public views of the NHS.
Okay.
Also, the qualification on if you're prepared to pay more, is that via taxes or specifics for services? As we've seen over recent years, where people are paying for dentistry, people are paying for optical services. So I think there's a lot of undercurrents that we need to understand, and I'll just make my general point again. I'm a bit worried about absolute statements. Yes. Going back to the homeless one, just to finish off, I spent a number of years as a trustee of a homeless charity in North East Lincolnshire, and we're not talking about one group of people. It's multi-stranded. There are, if you're thinking rough sleepers, which is a completely different thing, there are very, very few actual rough sleepers, very few. There are hundreds of sofa surfers. There are hundreds of people who move from place to place to place. But when it comes to people sleeping rough overnight, and these are the people who cannot access ambulance, there are actually a surprisingly small number. And I've participated 3 times in the annual counts, which are done at different times of the year and start at midnight. And I've been round, and I think the most that we ever counted in North East Lincolnshire on one night was 6. You know, whereas if you go down the high streets or the shopping centres during the day, you'll see people sitting with rolled up sleeping bags and things. They're not sleeping rough, most of them.
But don't have a home. Peter.
Just picking up on the point about inclusion groups, I think we've all seen the JCABIS tour data, which shows when you get beyond the most deprived decile, then the inclusion groups is just so starkly awful outcomes.
Yeah.
And as we develop the insights packs behind our strategy priorities for children and the Big Four, etc., I think we could take an action today to mandate that we will have a more detailed section on those inclusion groups with anything we do around insights, so that as we start to populate our website with data which is usable, which says something about the state of Humber and North Yorkshire, we've got that really sharp enabling focus so that other people, because it's like Stan says, we think we know it, but we don't actually know it in the depth of the lived experience.
Louise.
So briefly, just to build on what Pete's saying there, we do have the priority in the Pop Health Board around inclusion health.
Yeah.
We just need to connect some of this together, don't we, in terms of who's taken accountability to lead some of the work. But it is cross ICS and ICB.
Thank you, Louise. Teresa and Brent, and then I'm going to draw this conversation to a close. So Teresa first.
Thank you. So whilst Stan, I'm pleased to hear that it's only 6. I think the issue is that's 6 too many.
Yeah.
And as we're sat round here now, we don't actually understand the totality of services that are supporting or not supporting those individuals. And my challenge back, if it's only 6, that doesn't sound too big a task to actually deal with really quickly and make sure that they've got access to services and access to the facilities that they need.
Thanks, Teresa. Brent.
It's the YAS report again, and building on other comments to some extent, but thinking about, I suppose, that we're a big and diverse system across the 6 places, and one of the things I would say is that there's probably the elements of a really great services out there spread across the 6 places. So I'm thinking about, some of the things in the place where I generally operate, we're working with veterans in Hamilton, Richmondshire, the REACH project, which is award-winning in Scarborough, we're working with housing and mental health services and so on, substance misuse, etc. across the board. There's something about, I suppose, and I'm not going to be an operating model bore, but there's something about how do we gather the learning and bring all those different elements together to reflect on what can be brought together as a core sort of approach. I don't know whether Iris has a role in that, or whether that's pure collaborative business, or how it works. But there's something, I think, for us to think about, I guess, some of the areas where we've been making progress in some of these key areas.
Thank you, Brent. That brings us to the end of that agenda item and moves us to Stephen's item. But just before we go there, this is what we've been working towards, isn't it? You'll see on the agenda of talking about our risks, but then focusing this board on those we serve. And we've heard a lot about service, haven't we, in terms of the last week. And the purpose of having these individual focused stories at the start of the board is to make sure we're in the right mindset for the debates that then follow. It's easy, isn't it, to get lost in the money, lost in the performance, lost in the numbers. What we have to remember is our decisions impact on individual people and their well-being and their health. So prefacing the board as best we can with these sorts of stories, this kind of information, is what we're aiming to do more of. So thank you for both of those items. I thought it was all hugely helpful. And let's move on, Stephen. We're not doing very well for time, unsurprisingly. Your item 10, and this is Stephen's overview.
Thank you, Chair. Well, I may be able to help with the time, so not be a very long overview, but just by way of intro, really, between that section and this one. And all of those points are important in that discussion, but just picking out what Jason was saying and what Jonathan here said, we just need to, I think, stick with the confidence that we've got, A, in the strategy that's on the table, and B, in our operating model, because the answer to the question, Jason, I think on any of these things, and the acid test is the leadership of the collaboratives, the leadership at place, facilitated and coordinated by this board and the integrated care partnership. So to make the point, it's not we've got a population health board that's very dynamic, we've got a clinical and professional group. So the operating model that we've got, the test of that is, does it take the learning from the Health Watch report? Are we making sure that everybody understands that in those leadership roles? And then it's integrated in with the day-to-day leadership and delivery against the strategy we're all signed up to. So I know that's not rocket science, but that is what we're trying to do. So look, I mean, the two or three things that I want to pick up, just to flag. So I just want to register two concerns about the here and now. They're later on the agenda, so I won't spend a lot of time on it here. I'm going to ask Jane just to feed in on the industrial action position afterwards, and then I'm going to ask Max just to update us on one or two things on the EPR, electronic patient record, and then I'm just going to finish with, which does really chime in with some of what we talked about, the three big strategic shifts that our new government, in terms of the NHS, and actually I think it's health and care, capturing all of that, are focusing on. So my two concerns are, in the here and now, the emergency care services and the outcomes from that. Performance is one thing, and for the record, our performance is not good enough. It needs to be better, and we'll talk a bit about that. But I think the thing I would emphasise is what Teresa was saying, is we need to be very mindful of whether it's the elderly, frail person or the child in our system, and some of the quality challenges that are being faced there. So I can flag that. The second thing, and it comes back to what Charlie was saying, so that aspiration around the shift of resources, outcome-led resourcing, however you want to put it, that means that to get there we need to have very strong and successful financial management. And we've got some significant risks in relation to that this year. The reason I flagged what you said, Charlie, we need to think about that in that context that you set for us earlier. But nonetheless, these are two immediate short-term challenges that will deflect us from our overarching purpose if we don't get a grip on them. So that we'll come back. We'll come back to that. And when I say we, I don't just mean the ICB. I mean the collective system. We're all playing a role within that. So I'll come back to things I want to say, but I'm going to go to Jane now. Just give us an update on if you would, on the recent and prospective, I think,
Yeah.
industrial action that we have.
Yes, so just for people's information, we had the junior doctor strike for 5 days that ended on the 2nd of July. There's no further strikes been announced, but the BMA have indicated there might be further strikes over the summer, and clearly we've got messages, I think, in terms of West Streeting, meeting the union, so we'll have to see if that is a positive outcome. But in terms of the strike itself, during those 5 days, there were 1,285 cancellations, which was 137 inpatient appointments and 1,148 outpatient appointments. I think it's probably worth saying, though, that those are cancellations, but if people planned to reduce the activity, I don't think we've seen the full impact in terms of the strike itself.
No.
So you need to take both those things. But I think just one thing that is positive, that's a decrease of 815 cancellations compared to the last strike. So in actual fact, I think we're prepared, but I'm just not sure if providers actually planned for the reductions in activity. So that's one thing. And in terms of the numbers, the overall percentage of staff striking was similar, and between 60 and 100% of BMA junior doctors at any point in time, so it's different over the 5-year period. So that's the update on the junior doctor strike. In terms of the other industrial action that's looming is the ballot for the GP collective action. So that opened on the 17th of June and closes on the 29th of July. The collective action basically means it's potentially like a work to rule, so I don't think there's any, don't forget GPs are individual practices in terms of their own independence, so this is different. So what we can experience, the BMA have published something called a GP Practice Survival Toolkit, which sets out some of the actions, the 9 actions that they could take that wouldn't impact in terms of breach of contract. And there are other things as well. So we have, in terms of the GP contract, we have things like what they call directly enhanced services, DESs, which are national schemes that GPs get paid for doing additional work. But there are also things called local enhanced services that you might have different, and we've got a different pattern of local enhanced services across our 6 geographies. And if they could decide to give notice, but they're under 3 months contract to give notice on that, so that might limit that action. But there are other things that GPs do that they would say isn't written into their contract that they could cease to do. It's a little bit like working to rule. So in terms of assurance, so we've got our primary care team, and we've had I had 2 meetings with the LMC last week, and I think that the challenge is going to be the unpredictable nature. If you've got 6 different geographies with 160 GP practices all doing different things at different times, it's going to be that impact. And I think one of the particular objectives is not to impact on patient care, but to impact on disruption, I think, in the system and providers. That was what was described by the LMC. And so we're getting a task and finish group up together with representation from all the provider sector about what could happen. And we're actively involved with the primary care team. So we won't know until the end of July, and who knows, there might be a positive outcome before then, which would be fantastic, but we do need to plan. But it could be quite choppy.
Is this over a limited period, or is this over...
No, this could be, it's in perpetuity. It's not like we're going to be on strike for 5 days. This is action that they could choose to take. So the LMC talked about this will be a lifestyle change for some GP practices. Will say, I'm no longer going to do this work. I'm not being remunerated for it. It's not in the contract, and I will no longer do this. And it could go on in perpetuity.
Okay.
Could do, or if there's a resolution to the fundamental claims, they could restore, but we just don't know. So because like I said, it's just up to individual GP practices because they are individual businesses.
Thank you, Richard.
I just wondered, thanks, Jay, if you maybe give an example or two of the mitigations that we think we might need to put in place should some of these changes happen.
So, for example, one of the things that we've started to do is look at those services that are out that we directly commission, called the LESs and the DESs, if you like, listing those out. What are the ones that have the biggest impact on patients, and what could the alternatives be? And we're starting off that risk assessment to start off with. The things that sit outside the contract, again, we're doing that kind of list in terms of what they are, and it's all. People are interested that all those kind of things are well documented through the BMA website, and we are listing those and thinking about what could we do. But I think it could have a massive impact on urgent care.
Yes.
So one of the actions is that they'd limit the the number of GP appointments to 15 minutes to the maximum of 25 a day. Is that right? Yeah, it's 25 a day. And so if people cannot access a GP, the default will be to ED.
From our GP colleagues at the table, is there a sense that most GPs are in support of this, that this is supported widely, or is it?
I think the underlying themes around it are supported. I think you'll have different practices having different thoughts about the actions and the outcomes for their patients. And that's slightly the problem. If we've got 160 practices all doing slightly different things, it's going to be absolute chaos, potentially. And it's not good for our patients.
No.
Because if you have a unified action, then at least we know what we're dealing with. And that is the problem.
Yes.
The other thing is, if people start to give back the enhanced services, it'll be very hard to reinstate them. Because they'll get used to just not doing them. So there's something that we're looking at really urgently about.
Could I just qualify something you said there, Nigel? It won't be absolute chaos because, going back to Richard's question, clearly we would have to take account through the task force and other steps to make sure that we're not in that position.
Yeah, I'll take that.
But it is the other thing to think about, we don't really know, going back to the BAF and the risks, potentially a very significant risk in time. But I just wanted to clarify that's not what I would expect. I expect significant disruption, etc. But we need to take collectively, with the collective we I'm talking about, including our leaders in primary care, to address that on behalf of our patients.
I'll take that comment back. You're absolutely right. That's not what I meant. So thank you, Stephen. I'm pleased that you clarified that. So I absolutely agree with that. There are mitigations in place. The main thing that GPs are there for is the best outcomes for their patients, and that's what they want to build for the future. I have a view on it, but I won't share it in this forum. But I'm hoping that we can get to a proper resolution for it, and then services continue.
And the view on the radio this morning was from the British Medical Association was that they had decent conversations with Wes Streeting yesterday, wasn't it? So we await.
And I think that's positive for any other negotiation that's going to happen.
Okay, moving on.
Okay, well, I'm going to switch to Max, if I could, just a brief update on some developments on the electronic patient records, another big programme.
Thank you, Stephen.
Thanks, Max.
Electronic patient records are the systems which our hospitals and services use to keep records of who they've seen, when they've got appointments, what tests they've ordered, etc. And they're the kind of thing that you only replace every 10 or 20 years, so it's quite a big deal. Actually, in Humber and North Yorks, we've got a number of our organisations going through the procurement process and the implementation process for their electronic patient record systems. And those systems, they're a significant amount of money to invest, and they come from a mix of local funding and national funding. So in the process of procuring these systems, we as the ICB are asked to offer letters of support for local organisations to seek national funding.
Right.
And in two of our organisations, they've got to the point of having selected a preferred supplier. So for Yorks and Scarborough and Harrogate, they've selected a preferred supplier for their electronic patient record system. And earlier this week, we sent in a letter of support to NHS England for those two procurements. Now, we're delighted about that. Those two suppliers, those two trusts, have the same supplier, which is great, which gives us an opportunity to share information more easily in the future. And then, in addition, over the coming week or two, we've a similar process going forwards for Huth and NLAG. They're running about 12 months earlier, so rather than being at a stage where they've picked their vendor and are looking for their final business case approval, we'll be offering a letter of support, as I say, over the next week or two for their outline business case, which gives them the permission to get out to the market and test the market for the suppliers that they want. So very encouraging progress, and we're looking forward to those procurements completing and getting into implementation.
And is it a long gap between this bit and the start of implementation, Max?
Rough rule of thumb, 12 months.
Okay.
This is a big transformational project for any organisation.
Okay.
And I think for us as a board, we should just reflect that, with 3 or 4 of our organisations going through this kind of transformation, that in itself is major transformation.
Yeah.
It will consume a lot of intellectual horsepower and change energy in the system over the next 2 or 3 years, particularly in our acute settings.
Okay, thank you, Max. Richard first, and then Jonathan, then Bushra.
Thanks, Max. I think you might guess what I was going to ask you. Opportunities for convergence between the first set of EPRs and the second one. It sounds like they haven't had a product select for the later one yet. What's our sense as an ICB on whether or not we actively support convergence, and what do you think the views in the organisations are?
Yes, thank you, Richard. So convergence refers to whether or not we can get all of these electronic patient records on the same platform.
Yeah.
Theory being that then you can have easier flow of information for when patients get care across multiple organisations. So that is definitely our intent. We've asked the Huth and NLAG procurement team to make sure that in their selection process they take seriously the benefits which suppliers offering an integrated solution might bring to the outcomes that their patients can receive. I think the only thing that we have to also think about, though, is that that may mean the best integration is with systems outside of our patch, because that may be where a lot of patients flow, or it may be that integration is key to ones that are inside our patch. So convergence and the ability to give the best care to our patients is in that procurement process, and is a key strategy around NHS England on their continued funding. But I think I'm open to the fact that needs to be in their decision making, but it may decide that convergence lends itself outside of our region than inside, because obviously we have limited flow between the north and south of our patch at this moment.
And is the Federated Data Platform the cure for all of this? Is that no? Okay, I won't go any further then.
Federated Data Platform is something which allows you to have a shared data instance, but it isn't the thing that does your transactions in the hospital.
Okay, got it.
Come back on that, Max. I think the interesting thing for me about convergence is less it's a technical platform that everybody uses and needs support. It's more about the standardisation of care on pathways that makes it easier for patients to move around and be treated in a more efficient way or a standard way across whatever provider they're with. So that's the interesting one. And the final point, if I may, was based on the excellent visit we had to the GP practices last week. I think there was quite a lot of discussion around the future of primary care systems, and again improving those over the years to come to make them more cost effective and to integrate better with these EPRs that we were just talking about there. So I think that's something that we mustn't forget about, because the current there's a degree of dissatisfaction with the kind of current setup across the region for primary care.
Thank you, Jonathan.
Yeah, just to say, ourselves and York are doing this lockstep completely together. So it's a joint programme, jointly managed. I think some of the convergence, the Yorkshire and Humber care record, will be possibly the opportunity for doing some of that. And I think, as has been said, we've got a technical implementation, but the bigger issue for us is we've linked it to a kind of continuous improvement programme so that our clinical processes are changed. That's probably, it is the most important thing. We don't see this as a unplug one, plug in another, and the world carries on in the same way. It has to be linked in with clinical process change as well, which we're trying to do.
And the expectation would be that the acute collaborative would pick up that learning and improvement and roll it out.
Yep, absolutely.
Bushra.
Fine, I'm a well-oiled board. Richard slightly stole my question. Convergence notwithstanding, because I think I'm closer to Sue's understanding of tech. I just wanted some assurance, really, that in this process, particularly from a board perspective, because we can't really control the providers, are we certain that interoperability with primary care and community care services has been factored in and is going to be good enough before we get to a level of convergence?
Yes. I asked that exact question at an internal strategic senior leadership committee meeting for digital across the system last week, and was told yes.
Thank you.
Charlie, then Nigel, then we're done. Charlie.
Thank you. I'm very interested to listen to this, partly because I see echoes of it within my own organisation. And within my own organisation, we are saying you're not having the optionality to do things in different ways to perform the same functions. I can imagine that there are tremendous benefits like those that Richard pointed to, and I can imagine that there are simple workforce efficiency benefits if everybody has the same system. Should there not be an expectation from this board that there should be commonality of systems?
I let Max describe some of the journey. This is a journey that's been taking place for a long, long, long time, isn't it?
Good question, though.
Yes, I think that commonality is a good thing, and the ease of interoperability between systems where you've got common IT infrastructure behind it is definitely enhanced. I think there will always be local situations that require people to operate in different ways, integrating with different services, and the really delicate balance here is to marry both the ability to localise, to operate differently in place, with the efficiencies that come from having a single underpinning architecture and getting some of the basics in place in a common way. And that, I think, is the delicate balance that we're trying to strike here. And I'm as Stephen alluded to, we've come an awful long way in the last 6-9 months in terms of our approach in Humber and North Yorks and the likelihood of convergence. And I'm feeling increasingly happy with that direction of travel because we can see a lot of that emphasis coming out in the way in which the procurements are being run and giving us the opportunity to think about how we configure not just IT services but also then the care delivery services off the back of that technology.
Good question, Charlie. Nigel.
There seems to be big push from the new government around growing the economy and the UK supplier market. So I was just wondering, are there UK providers that will grow into this space, and will we be pushed more towards those or not? It's just something that seems to be really clear from the UK government about.
Well, maybe just to, I think it goes beyond technology.
Yeah.
That really is about capital per se, isn't it? Investment per se. So I think that's the strategy. Yeah. Let's hope it's successful. Yeah.
Jane, one final comment.
Yeah, so just I suppose in answer to like Charlie's point really, so I think we've found ourselves in this position because of the national funding of EPRs. So the EPR funding was given to providers based on like a digital maturity assessment, and so we've got funding for York and Scarborough and Harrogate, quite significant funding, and very little funding for Hull and Enlag, which then created a different pace in terms of ability to go out and procure an EPR. And that's where so it's the context that's made that challenging. So, and again, that's the vagaries of NHS finance and how it works, which we'd all, if we'd have all got the, a reasonable amount of money for each of the organisations, we'd have been able to do that procurement in the way that you described. And notwithstanding the point that Max made, again, we have to do a legal procurement. So whatever happens with Hull and Enlag, they will still have to go through some, it has to be legally compliant. But it is the situation that it wasn't desired, it was unfortunately just how the money flows into the NHS, which we all know is a little bit perverse sometimes.
The only other thing I might add is just a note of positivity as well around the way that our governance arrangements are operating. So we do have an EPR programme board, which is chaired jointly by a chief exec and a medical director, which is operating, it's meeting regularly, it's holding to account those different EPR implementations. So I think I also take some comfort around our governance arrangements.
Yes. Yeah. Thank you, Max.
Shall I move us on then?
Yes, please,
So
Stephen.
just to finish, let's turn back to, I mean, inevitably a new government, a fresh start, a degree of optimism maybe, and I think it's quite clear pace with this new government. And I think the opportunities that the next 18 months present is what we need to think about. But there are three big strategic shifts, at least been described as those. Happily, they're all reflected largely in our strategy. The first one is about moving care out of hospital into primary and community. And I would add, there's clearly a social care, Jonathan, wider local government dimension in there. It's not just better for patients and obviously people who use services, but actually it's vital to use our hospitals properly. Actually, the more we can do that, the more we can use the hospitals that we've got to deliver better, swifter, better access and swifter, high quality care. The second one is, which we've just been talking about, is utilising technology and data. Now, when you look at the blurb, it says offering the opportunity to deliver more effective use of money and staff time. In other words, productivity. And I don't think we should be in any doubt, and we talked about it here, but that this government will be as focused, if not even more focused on, hyper productivity, really. Particularly, and what we need to think about is how does that work in the context of systems, integration, pathways, and so on. And I think one of the fundamentals there is if you don't actually have some alignment, as you say, Charlie, of some of these key pathways, then it's going to be quite a challenge to get there. So, and part of it also is about giving patients, which you were talking about, Teresa, and I would say communities arguably, more convenience and control. And the commitment to staff that's wrapped up in that, and I think it's quite. I think it really is, and I think there's a lot of goodwill about the primary care on a negotiation with the GPs, and let's see where that goes. But that's going to be a real test, I think, in the next couple of weeks actually to see where that lands with the conversations that are already happening. And the last one is boosting prevention and all that entails, and we know that that's all about partnership working. It's all about devolution and so on and so forth. That is genuinely about how place operates. I think it's quite interesting that the Prime Minister has called together all of the mayors across the country and creating a forum within which those mayors can come together, I think driving devolution. Now that's a very live issue for our ICB and our system. We've already got combined authority in Yorkshire, as we know, and they're coming on stream in Hull and East Yorkshire and in Lincolnshire. So it's very firmly in our sights, isn't it? But I think that presents a lot of opportunities. So that's all I really want to say. But leading on from that, in very specific terms, we've talked here before, and we won't go into it today, but we will, I'm sure, as we go through the summer, about what we were calling our Design for the Future work, which has been taking place the last 6 months, which is about how should our services look, and then once we've, as it were, answered that question, how do we organise ourselves in the context of collaboration, integration, etc., to deliver what that new service model looks like. So we've done all that work. We're in position within the next 2 or 3 weeks, as we plan to go into a process of engagement around our design for the future. And we shouldn't underestimate the intense nature of that and the time that will take to do well, with a view then that by the end of September we have a firm set of proposals that we can take forward, in effect, to the new government, clearly through all of the processes that we would follow to do that. Remember, that is our plan, and wrapped up in that plan are some very challenging, I think, decisions for us to take, not just around this board, but collectively as a wider system. And then my last point, which is really part of that process coming up, is we've got a good number of new members of Parliament on our territory. So, Chair, you and I are going to be spending quite a bit of time, along with others engaging with those new colleagues to try and get as much buy-in as we possibly can to where we want to go. Thanks.
Thank you, Stephen. I'm looking, I don't think anyone has anything they want to ask further, so I'm quickly going to move the agenda on before someone decides that they do. Let's move on to item 11. This is the performance report. And Jane, this is from you.
Yeah, thank you. Thanks very much, Chair. Just before we go on, I'd just like to say that we've significantly redrafted the performance report, and that's with thanks to Karina's business intelligence team and the performance team. It's quite significantly different, and what we tried to do is retain some of the positive messages from the National Making Data Count programme that gave our performance report really positive feedback and said it was one of the best in the country, interestingly. So we tried to retain the best thing. I think the other thing to say is that the performance report is for the system. It's not, it's not the ICB. This is about how the system performs, and it's trying to align out with the operating plan. Also relates to the strategic objectives. It's trying to make that link in a much more explicit way than we've probably done in the past. And I think the other thing to say is that, in terms of our governance and the membership of this board, with representation from all the cooperatives, and this is about everyone's performance. It's not the ICB, and I think that's a really point. And I think when we get into some of the discussions about performance, we can have those live conversations with the wider leaderships. I think that's a really good point. And then one final thing is that the underpinning governance that probably reviews this and speaks to the providers who are delivering this performance is through our system and oversight and assurance group. We had a good meeting on Thursday last week, and we've committed to have a couple of workshops about how does governance work in our system in terms of our oversight, both in terms of providers collectively and also individually, but also what we're doing through the collaboratives. We also had a good meeting this week at the Leaders Forum about how we almost like have a mandate for each of our collaboratives and places. So how, what are the objectives that they need to achieve, and how do we hold them to account? And then what does it mean for the performance report? So all that is, sort of like taking a bit of stock. How does all this work?
Yes, okay.
Is it as effective as possible? So in terms of I'm not going to go through the parts. We've got a really good summary document which describes where we are, and we've also got the deep dive into urgent and emergency care in this report. So in terms of I think in terms of the priority indicators, I'm just going to quickly go through a couple. So from, just one other thing to say, Chair, is also I think the age of data, and I think that's probably, I'm sure if people looked would say, we sat in July and the data is April. Again, what we talked about in System Oversight and Assurance Group was we can use unvalidated data. The trouble is with the NHS data, it takes so long to validate that it feels like when we're looking at the data, it's really out of date, and the world has moved on. So we do think it's appropriate for SOAG to start moving to what I'm going to call unvalidated data. And we think we're probably going to do that, so we've got more live performance. But I do think in terms of the trouble is with a public board meeting, we're in a position where we probably need to use validated data, which has a bit of a time lag associated with it.
The great worry for me for the board is that we miss something. So there's something changed. There's some kind of trend. It takes off in March, April, May. This board isn't cited, and the first thing we see in July, is that there's been a big change, and we aren't cited on that. That's what worries me.
I wonder if we might need to reflect on that, Karina. We might have to say that these are some of the... Sorry, Karina's got a hand up anyway.
Yeah, sorry, thank you. I suppose my response to that for you, Chair, would be if you look at particularly one of the slides in here, the view by month, that's starting to give us a trend over a longer period of time.
Yeah.
So if you look at some of those trends, you can see that there are significant areas where we're already saying for the last 12 months we have been completely off track.
Yeah.
The high probability is that that's going to remain for a while.
Yeah.
We can see some of those trends. So actually the report is presenting some better information for the board to understand some of that.
Okay.
So even though the data is April, if you look at the trend, you can see some of that already.
Yeah.
You don't necessarily. It's not a concern for us that you haven't got July's data, for example.
Yeah.
You can see the trend. What we try to do is supplement that in the narrative with the most up-to-date position, so you can see if the trend is heading in the right direction.
Thank you, Karina. Teresa and then Stuart.
Yeah, I think you may have just covered it, because I think one of the issue is, I think, for the board is any deterioration that is significant, that won't necessarily be reflected in the trends. So if we're clear that the commentary will include a note of unvalidated data suggests this is what we're going to do about it, or keep an eye on, or whatever. I think that's the point, isn't it?
Just a further point of assurance before you go to Stuart. The reality of that, I would expect, and through experience, is that chief executives in our system will understand those trends without necessarily having to look at data, and that if our system, which I'm confident that it does, that if our system works well, then we would at least have some sense of that. So just to add that to what Karina has said.
Stuart.
Two associated points. I have no problem at all with unvalidated data as long as it says it's unvalidated. I will understand if it changes. I think the board could cope with that. The other is, which is a point we made in the conversation we had yesterday, the timing of this board each month doesn't really help with this problem of ageing, doesn't really help with the finance reporting either. So we might consider being slightly later in the month in order to get more up-to-date stuff that's been signed off and is validated. So perhaps we could have some sort.
There's a revolutionary thought provided by the NEDs yesterday. Wouldn't it be better in terms of information flow if we had our board meeting at the end of the month?
From 25-26, Chair.
And they're right, it would be. So we'll need to make that shift. Richard?
Yeah, it's a thanks, really. I think it's a lot easier to consume.
Yeah.
It's a big step forward. There's obviously a lot of work gone into it. So thank you for all the people who've been involved in that. Kind of an observation that I made yesterday. I think there's a tendency that the measures we look at and the things that we improve are the nationally set ones.
Yeah.
And I suspect over time we all want to rebalance that and have more scrutiny on primary care, community care, mental health care, where you tend to get significantly fewer measures because they're not nationally mandated in the same way. So I think that's a development for the future. I also just want to make the point that a lot of our data sets and data reporting is based on what we have to report nationally. I think there is an opportunity for OCB over time to put our own infrastructure in place. And I think some of the interesting things that we heard about from Karina and others a few months ago about developing our own data warehouses, our own way of looking at data analysis, and indeed possibly even the federated data platform in the future. So I think there'll be things that we want to do as an ICB over the next couple of years which aren't related necessarily to the national reporting that we currently do. And that's a really good opportunity, I think, for better assurance.
Thanks, Richard. Charlie, Anya, Jane. Teresa.
Prompted in part by Richard and picking up earlier points, I've got my eyes on the prevention and health inequalities section here, which has 4 indicators, all are very important things, one of which has been prioritised in part because it's easy to measure. I worry that that's a whole lot of narrow frames.
Yes.
All important, but they're all narrow. And I'm quite interested in the scope to add things that we think are important. And one of them under that prevention of health inequalities section could well be, what's the proportion of spend we're committing to that area, and is it high enough?
Yeah.
And Stephen, you mentioned this before, and we've considered it in some sense as one of the ways in which we could shift the priorities of the system. So shouldn't we be saying, we expect X% to be spent in this area or in some of these other areas, rather than simply looking at the narrow indicators, which may well be a reflection of how we spend our money, but we might be able to do more.
Yeah, I think the more we can connect our activity to our money and we bring the two together, the better that will be, and the return on investment for those things we invest in as we go along, really critical.
Could I just suggest an action, and you maybe Jane could cover that, is I think this is an important thing, reinforced by where the new government is, and particularly about our own intentions. I just think we ought to have a conversation about this issue with some information. And I think we haven't actually made a decision in the board following on from our time out about that. So we need to do that, I think. So I'm just flagging that as an action.
Lovely.
For we can work out whether that's August or September. That's I think we need to do.
Thanks, Stephen.
Yeah,
And that would influence those things.
Can I just respond to Charlie, really?
Yeah, you can.
So this, I think, if you look at the description, annual operating plan performance report, and that's what this is. And in previous organisations, when we did this, we did like a strategic scorecard that was done on a quarterly basis because some of the indicators are slow moving, and perhaps that's something we need to think about. So what is our strategy? Now there are different indicators, because I think this is doing the report that we need to do, because we sit all around this table in lots of meetings in NHS England, and the board need to be cited on it, and we all need to be cited on where are we with our operating plan. But I think a strategic scorecard, I'm going to look at Karina because it's certain, but I'm also thinking about Stephen, I'm going to say the son of the Grant Thornton work streams.
No, exactly.
It's moving on to, it's how we do the things that are important. So this is the stuff we're going to get measured on. We all need to understand that. But what are the important indicators? And it might be that we don't do that every month, because these are sometimes slow-moving indicators. You might want to do it quarter or whatever. But I think it's probably going into that territory, isn't it, Karina, really?
And it's an important way of holding ourselves to account, isn't it, for what we do, what we invest in, how we spend our money.
Yeah. And it is. And I think there was a query as to why we've got two very similar looking diagrams at the front of the report.
Yeah.
I mean, and Jane's just mentioned that the title is "This is about the annual operating plan," but we are creating a suite of other performance reports that deal with all the other aspects. So Jane's point about the scorecard, the link with the artists formerly known as Grant Thornton programmes. So there is work going on to develop this further, and it also links to the outcomes framework, which links into the integrated care partnership.
What I think is really important is we discuss it as a board to really hone down and crystallise what it is we want to go. Otherwise, we could end up with, because there's a lot in that, isn't there? Detail in that. So I think we do need to have that conversation with a bit of information and data to back it up. To design that, in effect.
Yes.
So I don't think it needs to be too complicated.
Yeah.
Teresa, Jane, Louise, Stan, and we're going to move quite quickly, please.
Okay.
It's a very quick point. I just wanted to come back on what Richard was saying, and I know he's not necessarily saying this, but I just want to caution the bit about different data rather than the nationally reported data, because at the end of the day we've got to be clear about the data burden on providers. So it may be a question of analysing the data that we have differently, so we look at it through a different lens than necessarily the national team are doing, and I'm sure that somebody's going to say things like the federated data platform will allow us to do all that, and I'm sure but I think that the bottom line is about the data burden for providers.
Okay. We've all been to the FDP workshop, Max. We think it's going to change all our lives. Jane?
Yeah, mine's a really quick point. So you will notice from the report that there are still gaps on the workforce data, and we're trying to make sure that you get that ready for August. It does report to the Workforce Board, not the Finance and Performance Committee, so that just needs changing in the pack. It's got the wrong committee.
Anya Louise.
Thank you. Just building on the points made by colleagues, and firstly to say again thank you. I think this is a great improvement to the report. I guess it's about something we've talked before around what's the colour, the details that sits under some of this, in terms of can we understand if some parts of our population are more or less affected by some of the things that we're seeing here. As an example, we know from some of the previous reporting that some of the people that are waiting the longest on our elective list are women waiting for complex gynecological procedures, but in itself, is that something we as a board need to understand? And I'm not sure if there are other things there. We've spoken about some of the inequalities piece, but personally I think that is important for us to really look at as a next step. And again, I think building on the comments that others have said, you know, what are the key things in this? And the summary report, Jane, is super helpful, I think, but are there particular things that we as a board should be concerned about? So one of the things that absolutely jumps out for me is the longest community waiting list. It says that the majority are waiting for speech and language therapists for children and young people, but that's on a waiting list for 2 years. So it's understanding what is the implication of that when radically improving outcomes for children and young people is, you know, one of our key ambitions. And I think there's something about just pulling out and surfacing that and perhaps giving the board further assurance if that is being addressed, and or if there are further actions that the board needs to consider in relation to some of those key points.
I think that's a really good point, Anya. And what we've fallen into the trap, really, haven't we, of talking about how we receive the information and what it looks like, rather than the actual issue, which is the performance of those organisations with whom we work. And that's a mistake. Louise?
Yeah, I mean, I welcome the session that Stephen's suggesting. I think we do need to have that to follow up on the conversation around how we invest resource. And I think there's a difference between service utilisation and how services are performing versus the need of the public health. And how we just think about public health intelligence and population health. So bringing that together, and simply, because we could just be awash with data, couldn't we?
Yes.
But actually, how do we intelligently use it? And we do have the challenge around our core 20+5 and making sure that we do reduce health inequalities, which is what you're sort of alluding at, Anya. So, I think we need to have a session on that, about how that then links to money in terms of impact and what the population's health shift looks like, not just service utilisation and activity.
Thank you, Louise. And finally, Stan.
Thank you. I think we need to do a little bit of a dive on the mental health out of area of bed placement, which seems so far out of target, but it seems to me, you know, we're a big place. You know, we have 6 places within the region, so I think, you know, it's counterintuitive to me that we've got. What do we mean by out of area? Is it?
Brent, do you want to just clarify this?
By all means, we could spend more time on this, Chair, if you want to.
Not too much,
meeting.
Brent. Not now, but in future.
Deep dive in it.
Definitely in future.
Yeah, I mean, there's obviously a number of factors in terms of what we mean by an out of area.
Exactly.
It could be somebody actually down the road in an independent sector bed, as opposed to the locally commissioned NHS facility.
Okay.
Or it could be somebody right across the country.
Yeah.
And either way, what we're trying to do is to get them
back
into the normal lines of commissioned activity.
It just seems so far out of target that, you know, it does. I know the numbers, the absolute numbers are small, but it's something we need to.
And it's an area for greater change.
So I think on the point about process, which it's an important point, because there's a number of things here you can said the same about different contexts. Back to what Annie was saying, remember that that's one of the reasons we've got the collaborative chairs here. Yeah. Now, let's not go into it now, but for my money, when we're getting into this, our job isn't to deliver this, actually. Our job is to ensure that it's happening.
Yes.
And one of the reasons for having Brent and Jonathan and other colleagues here, only one of the reasons, lots of other very good reasons, is that we get the assurance from them about that. So I think that comes back to how we discuss this when it's presented. But I think that, you know, we don't need to spend a lot of time on that now, but that's the way we need to go with
Teresa, tiny comment.
Tiny comment. I just want to link it back to the discussion last month about the future of the mental health collaborative.
Yes, indeed.
Because one of the key issues and why we're focusing on changing the collaborative into the future is actually about putting the finance where basically the people can make a difference. So I think it's important to link those two things.
Yeah, thank you. And actually, that reflects much of our conversation this morning, doesn't it? Okay, we're going to move on to item 12, which is the finance report. This is a verbal report, isn't it, Emma? And I'm thinking it's not a long report for us. I'm therefore going to suggest that we have our coffee after the finance report, so everyone can have a break.
Absolutely. No,
so, Emma, to you, please.
That's lovely. Thank you, Chair. Yeah, it is verbal, but that doesn't mean that there's not a huge amount going on finance. I think is obviously the first thing to say, and this week in particular is a really crucial point in the year, given that we're just about to try and land the Q1 position. In a similar vein to what Jane said, what I'm about to say is about the delivery of the integrated care system finance, not just the ICB. And obviously, coming back to Stephen's point, this is about assurance around delivery of our wider system, and obviously involves us using influencing and sort of distributed leadership models in order to do that. We have had a series of escalation meetings over the last couple of weeks with both directors of finance and chief execs within the system, and so I was just going to go through very briefly the feedback from there. I do want to be really clear that we're actually focusing our attention not just on variance analysis. Again, we're looking firmly at the run rate of expenditure now, so turning our attention to what's happening on expenditure levels, and particularly linking with Jane and the workforce group around what's happening with the cost of agency and bank and some of our sort of high cost areas. So that's one key feature of some of the change that we're deploying. And the other area of focus is very much on efficiency, and I know that we've talked here about the risk to delivering levels of efficiency within this system. So I was going to very quickly go through where we are with that, but I think just hearing the conversation, I think the trick is that we need to deliver in 24-25 to enable us to focus on long-term planning, and that's a fundamental theme that's coming out from nearly every part of the conversation we've had. But 24-25 is year one of our medium-term financial plan, and actually us delivering on the key elements of that, the operating plan and the financial planning this year, is the foundations for that future sort of sustainability. And we need to be deploying continuous improvement techniques in the world of finance and process in the same way as we do with a lot of the clinical workforce, again, that we've talked about. And I presented to the SLT of the ICB yesterday to try and sort of kickstart some of that different way of thinking. Again, I've been in the system a long time. Some of the barriers to integration actually is organisational focus and cultural barriers, not necessarily the money. And I think actually understanding what's driving some of the barriers to integration in a really deep way is something that we need to absolutely get under. And the Integrated Care Centre is both an example of success on integration, but also a failure of integration, because we had to move the employment of some of the staff out of one organisation into another to enable that to happen. Yeah. That is not right, and I think it's fantastic learning that we need to build into the next few months. So, in terms of the feedback from the escalation sessions that have happened with chief execs and directors of finance, I'm really pleased to say that there was a reconfirmation of the commitment to delivery of 24-25. The financial plan within the year. So that's notwithstanding the significant level of risk that obviously exists within our system that we understand. So first of all, that's really important. We did agree a number of actions, as I say, feeding into the month 3 position, that we would look to be as appropriately realistic but positive about the action that we're going to be to take to deliver operating within our financial envelope for the financial year, which is, again, really, really positive. We went through the whole series of efficiency plans that are in place within our individual organisations, and a huge thank you to recent employment of Matt Lowery, who is working with the Collaborative of Acute Providers, so the CAP, and coordinating a really clear view of comparing what's happening within our organisations. And he has identified some fairly significant opportunities for levelling up quickly in this year that will mean that our unidentified efficiency levels for the system go from somewhere just sub 40 million down to just over 20. Now, I know that's not us having nailed the entire identification of our efficiency ambition for the year, but it's definitely moving us in a significant direction.
Is that back, Emma, to the thing that we've been talking about in a number of different contexts around consistency between organisations?
It is.
It's a bit of a theme this morning, isn't it?
Absolutely, yeah, absolutely. And again, we can go into that at another point, but things like...
We ironed out those inconsistencies.
We did.
In the meeting you talked about with the good offices of Jonathan and his colleagues.
We did. And the features of that was very much around outpatient transformation, theatre productivity, some of the big areas of opportunity that we've identified through the system change and transformation agenda, son of Grant Thornton. So in terms of cash, that was another key feature that we discussed within the conversation. Obviously, cash is a really real indicator of revenue and financial distress or not. And I think it was really pleasing to hear that every single organisation within the financial control circle that we operate are saying that once they receive their share of the 50 million deficit support allocation funding, which will be coming, there will be no further requests for cash support forecasts within the financial year. So that's incredibly positive, and obviously something we're going to be keeping a really close eye on. Finally, we talked about really sort of having a clear understanding of what we're doing around investment decisions and making sure that we have a genuinely system-wide view and process for any discretionary spend that we make, both as an ICB but within NHS organisations. And I committed to convening and coordinating that work with DOF colleagues across the system. And that'll be happening again. It's a busy week, so I've got lots of big bags under my eyes. So in terms of that, I think that was everything I was going to say.
Did you report on the ICB's position?
So from a month 3 point of view, so yeah,
to do so.
As you say, the timing of the board doesn't always sort of align to the most timely opportunity to report. However, we have got the first cut of the ICB position, and again, not underestimating the level of risk, but we do look like we're holding our own on some of the influenceable spend areas, so things like prescribing, continuing healthcare. Again, massive caveats. We're very early in the year for the data flows that support that, but it looks like certainly the work we're doing on the continuing healthcare section 117 work, do once across the system is showing some early shoots of positivity. So yes, it's looking like we will be reporting a break-even position for the ICB, and I'm anticipating we will be as close to plan for the provider organisations, but we'll know that later today when the numbers come through.
Okay. Stuart, and then Jonathan.
Emma, thank you. Can I understand the efficiency point you made a bit better? So, this gentleman, Matt Lowry, what's he been doing? He's been finding good practice in one place and encouraging everybody else to take it up. Is that basically what he's found 20 million of efficiency?
Potential, just short of, and Jonathan, Jonathan may want to come in.
Yes, and this was helpful in terms of the meeting that we had about 10 days ago, I think, when we were all in the same room, and I suppose there are different risk appetites and different levels of commitment in each organisation, which doesn't mean that we're not doing the same things, but our putting a flag on to say we will deliver that is different in different organisations. So testing that across the collaborative acute provider has been really helpful, so that we've got to a point now where that piece of work means actually the vast majority of the plans, and I'm speaking for the CAP as well as just Harrogate, will be identified, because that's step one, isn't it? We've got to do what we say we're going to do, and then we have to deliver what we say we're going to do. And it was interesting that Emma said reaffirm the commitment. I don't think that anybody has never been committed to delivering this, and I think what's really important is this is this year. This is short term. We have to do what we say we're going to do. That will give us the credibility, both internally and externally, buys us the time, gives us the headroom to do some of the stuff that we will need to do for years 2, 3, 4 and 5, and some of the shifts that we've talked about. So there's absolute sign up to doing that. It doesn't mean things like industrial action don't throw spanners in works occasionally, but those can all be managed. So I think the work that's gone on over the last month or so in terms of pulling some of those things together means we've got a much clearer view across the system of where the efficiencies are going to come from, and the focus now is on making sure we deliver them rather than trying to find them. And I think that's a step forward. It's July, so we're a quarter of the way through, so we have got work to do, but we've got a bridge from now to the end of the year, which, with risks and all those sort of things, will get us there. There is still a lot of risk in there. We'll have the usual questions about winter pressures. Got a new government, where will that go? Industrial action, we don't know, but in terms of having a framework in which to operate, it's in a stronger place, or a more consistent and understandable place now than it was months ago. And in terms of commitment, all signed up, always have been all signed up to what we say we're going to do. Helpful to go around the room last week and just recommit that. So if that helps the board in any way.
Thank you. That sounds like good work. Jonathan, I think you want to ask something.
Yeah, just a very parochial comment. I don't know how it's shared by the other local authorities, but your comments regarding continuing healthcare in section 117s, I think there will be a greater focus from our local authority position to make sure the costs are being properly apportioned. So, and I hope that's taken into consideration. I know there's a spotlight focus on that from our point of view.
It is, and if I can just come back on that, Che, I think that's a really good point, and this is about doing work that doesn't throw sort of financial pressure across the health and local authority boundaries, because we've all operated in systems where that might have been the case previously, and that is not a place we want to be. What we're trying to do is work together to understand what the opportunities to do better with the total place pound, whether that be in health or local government.
That's good to hear.
Jane?
Did you want to describe the stuff you're doing on market management with the continuing healthcare? Because that's really good.
It is really good. If we've got time, there is. And again, it might be an area to do pick up as a deep dive, because there is some really groundbreaking work that's been led. It's not necessarily financially been led. It's been co-led by myself and Denise Nightingale thus far, but really proactively engaging with the care market in a way that we maybe haven't done previously. And again, I know, Chair, you're aware of a specific example. Actually just sort of having fingers in our ears and pretending that these pressures don't exist and the challenges don't exist within our partners is not one that we want to be in. And so what we've got 3 sessions scheduled during July, full day sessions with the care market, local care associations, to actually proactively hear from them about what they need from us and how we work together to deliver a more sustainable offering across those boundaries in the coming years. And obviously, again, that features heavily linked to the design for the future and the medium-term financial plan opportunities. Thank you.
Thanks, Emma. Final comment from Teresa.
Yeah, just to say, sorry, I'm linking it back to the previous conversation about mental health and out of area, because we need to do a similar approach in terms of stimulation of the market to actually provide facilities.
May well back on that, actually.
Yeah, okay. Well, we look forward to learning more about that in coming meetings. Thank you all very much indeed. I think we've had a great morning so far. I do think you probably deserve a coffee. Now, listen, we're going to work from this clock, because you won't thank me if we're late for lunch either, will you? So let's say we are absolutely starting at 20 to 12, okay? Thank you. A little bit of juggling now with the agenda. So if you were expecting that we were going to do item 13 or 14, we're going to move those on till later. We're actually going to start with item 15, which is the very important matter of the Humber Acute Services Review. We've got visitors to the board today, so very pleased to welcome Lindsay, Alex and Kate. Great to see you. And we've got a very particular job to do now. So we are here to approve the proposed way forward for service change, which you've all seen on a number of occasions, which has been developed following the review of the consultation feedback and takes account of the key issues and concerns raised by those we consulted with. So this is the follow-up from the, is it a 16-week consultation, Anya, that we've undertaken? 14-week consultation which we've taken. So the plan is slightly amended as a result of that consultation. We're here to hear that, but we're here to approve the way forward for that. Now, I think the way this is going to work is Anya's going to lead off and hand over to the team who've joined us. Is that correct, Anya?
It is, Chair. Thank you. Would it be helpful if we just ask colleagues to introduce themselves before we start the item? Thank you.
Good afternoon, good morning, everybody. My name is Lindsay Cunningham. I am Deputy Director of Strategy and Partnerships with the NHS Humber Health Partnership.
Good morning, everybody. I'm Alex Sale. I'm North English PACE Director and Chair of the Hazard Oversight Group.
Morning, my name is Kate Wood. I'm the Group Chief Medical Officer of the Humber Health Partnership.
Thank you, colleagues. Are you happy for us to start?
I am, yes.
Perfect, thank you. So in your pack you can see there is substantial information relating to this agenda item, not least the totality of the decision-making business case. But what we thought would be helpful is to pull out the key points in a more digestible format. So we've got a short presentation that we will take the board through, and then there will be the opportunity to ask questions before a final decision is made, if that's okay. So I will start, if we can move on to the next slide, please. Most board colleagues will be familiar with this, but I will just take you through the background of the consultation process. So a very comprehensive consultation process ran at the back end of the calendar year and into the new calendar year. As we've just touched on, it was just over a 14-week consultation process. And you can see there the headlines in terms of the engagement. We worked tirelessly, I would say, to make sure that there was ample opportunity for all parts of our community that would be potentially impacted by these proposals to have a say on the proposals, and that included a range of different events, both open events and targeted events, a whole raft of other platforms including digital, face-to-face and paper-based activities. So you can see there the summary, and I think it is important to just give the board assurance that we've received two, if you like, high marks of assurance for that consultation process. One being the Good Practice Award from the Consultation Institute, and the second, the NHS Gateway Assurance process has recently concluded and has acknowledged the comprehensive nature of the consultation process that leads to the final decision-making business case. So if I could hand over to Lindsay, please, and then we will pass to different colleagues to take us through the slides.
Thank you, Anya. What I'm going to do is just give you some very brief headlines in terms of the feedback that we gathered through the consultation. Within your pack, there's a comprehensive report which was compiled by an independent organisation called ORS, Opinion Research Services, who specialise in this kind of work, in doing research analysis and consultations. And so what they have done is they gathered together all of the consultation feedback, so whether that was via the online questionnaire, the targeted detailed work that we did with different equalities groups, the really sort of in-depth conversations, as well as all the written responses from our statutory stakeholders and others. So all of that's in your pack, and I'm just going to give a a few of the highlights in terms of what the kind of key concerns and key issues were that came through the consultation, and then I'm going to hand over to Kate, who's going to explain how we've responded to that in terms of the revised proposal that's in the decision-making business case. So as well as looking at some of the benefits and case for change, one of there's two key strands in terms of issues and concerns that people had in responding to the consultation and the proposed changes. Some of the specifics, and I've pulled out on this slide here, and as I said, it's in the pack and it's in your DMBC, your decision-making business case as well. Around the specific 4 service areas where we were proposing to make changes, there are relatively small number of specific issues with those proposed changes, but I'll just mention a few of them, and then I'll go on to talk about what are the kind of bigger overarching themes in terms of issues and concerns that were raised. But in terms of the trauma unit proposal, the sort of key concerns that members of the public and some of our stakeholders had were around about how as a system we'd be able to respond to major incidents, industrial accidents, etc. As we've been developing decision-making business case, we've engaged with internally with our EPRR teams, but also with the Local Resilience Forum, the Humber LRF, who've looked at the revised proposal and are comfortable that it actually wouldn't have any material impact in terms of that ability to respond to major accidents concerns, because we would be retaining the emergency department, which would be able to respond to those issues and concerns. Around the specialist medical inpatients, as I said, very little specific feedback, but some of the questions and concerns people raised were around about population health needs and how we make sure that we keep those core services local, particularly around things like cardiology and respiratory, because of some of the population needs in the areas. And some suggestions coming through around actually is there scope to do more consolidation and have more specialist units across the Humber, which is something that we are obviously starting to explore now as part of that group model. In terms of the surgery proposals, the majority of the concerns people raised were around about specific surgical emergencies and how we would handle life and limb emergency situations in a scenario where you've got services consolidated in one site. And there are elements of that in current existing models, and we can talk through those if people want to pick that up. The main area where people did raise concerns was around inpatient paediatrics, and particularly listening to children, young people and families, and particularly those families who are regular attenders. Very, very small numbers, but make up a lot of bed days, particularly looking at children with long-term ventilation, etc. And so this was one of the things that we've worked through as we've developed the revised proposal. So if I just move on to the next slide. The broader themes, and these were coming through much more clearly in terms of the wider feedback. By far and away, the biggest concern people had was around about travel and access. How do you get to visit your loved ones if they're further away from home? And actually quite a lot of the feedback through the consultation was around, not around the specific services that were proposed to change, but a number of things that are already existing, and actually how difficult it is for people to access, whether that's people living in the Goole area to get to Scunthorpe, whether that's people living in rural parts of North and North East Lincolnshire getting to existing hospital sites, Scunthorpe and Grimsby. There are a lot of challenges that people raised in terms of the affordability of transport and availability. So these things that, and Alex will talk about these when we get later in the presentation. Another area that people raised was concerns about the impact on other services. So would it put an undue impact on ambulances because they're sort of moving patients further, or would there be an impact in terms of the capacity at Grimsby Hospital to take additional patients? And we can walk through, set out in the business case in terms of how those issues have been responded to and looked at and understood. And I guess the sort of final area that people did raise concerns around was what about the impact on the future of Scunthorpe Hospital? So sort of recognise that actually these proposals, they could understand the rationale and it makes a lot of sense, but would that mean that there'd be further changes, and how do we make sure we retain a vibrant service within Scunthorpe? How do we ensure that actually as a sort of an important town we make sure that we've got the key services that people need? So that was one of the other areas that came through loud and clear. And just the final slide that I'll touch on, and there are other elements that's sort of detailed in that detailed feedback report, but just in the interest of time I don't want to go through everything. But just important to pull out, we did spend a lot of time and energy ensuring that we heard from people who are less obvious to get to, people whose voices aren't always heard, and we did a lot of in-depth targeted engagement and really asking questions around the sort of the equalities impacts and understanding those. And by and large, and again this is reflected in the ORS report, the biggest concern people had was around transport and affordability. And actually when you look at the impacts, a relatively small number of people, but often they fit into many of these categories. So actually it's that's the lower income carers, parents, families, and so we need to think about, in terms of those mitigations, what we want to do that's very targeted, but at those people who would potentially be most impacted. So that that kind of summarises the core pieces of feedback. We also looked in detail at all of the alternative suggestions that people made through the consultations, different suggestions, and we reviewed all of those in terms of whether they were viable or not, and that's also fed into the revised proposal. So I'm going to hand over to Kate, who's going to sort of take us through what the revised proposal looks like in terms of the services and what we would be advocating goes where. It does reflect a change to what went out to consultation. This is based on the consultation feedback and also the detailed work that we've done internally within the organisation to look at the deliverability, how services could be delivered in a new way, and also ensuring that we really maximise the benefits, particularly looking at the surgical proposals. How do we maximise the wider benefits of the change in terms of improving our productivity, efficiency in that space, because clearly we've got a lot of requirement to do that in a sort of a wider sense. So I'll hand over to Kate, and I'll hang on to the clicker. I'll let you talk through the next
Thank
one,
you.
if that's okay.
Thanks, Lindsay. So just talking in a little bit more detail, and clearly I'm happy to take questions at the end. Our original proposal was that those 4 key service areas, trauma, emergency services, some medical specialties and paediatric overnight care, would all be consolidated to Grimsby. So that was our original proposal that went out to consultation. And as Lindsay says, through the discussions that were had and through the feedback that we had and subsequent revised activity modelling, there is a revised proposal, which is the purpose of why we went to consultation, I suppose. So before I get into the detail, just to say that originally with the consolidation of all those services to the Grimsby site, there would have been an impact on 14 people per day, so 14. The revised proposal takes that down to 7 individuals being impacted per day. So quite a significant change in the numbers of people that would be impacted. And if I just briefly mention a few of those areas. So with regards to the trauma unit, that has remained, the proposal stays the same for that consolidation through to Grimsby. With regards to surgery, the initial proposal, the impacts as we worked through them, it was recognised that we wouldn't actually be able to make optimal use of the capacity and the staff and the resources of the estate that we had if everything was consolidated through to Grimsby, which is why things have changed. And specifically, trauma and orthopaedics consolidate over to the Grimsby site, alongside our acute general surgery. Urology consolidate as is already the case in Scunthorpe. That was a temporary change that had been made previously, and that is recommended to remain as it is at the moment. ENT through to Grimsby, that already happens on a rotational basis between Scunthorpe and Grimsby, so that would be a permanent move to one site. And ophthalmology has changed very much from the original proposal, and is partly due to the coming together as a group across the Humber Health Partnership, that actually it is felt that ophthalmology would be far better based to be consolidated through to the eye hospital that is already in place within Hull Royal Infirmary. Gynae, you will see the suggestion is that this is retained on both sites, and that is because we continue to maintain an obstetrics service on both sites, and the interdependencies of those specialties of obstetrics with gynecology. It actually, as things stand at the moment, seems appropriate and logical to retain on the both sites and include in any future review that we do with regards to obstetrics. Our medical specialties continue to be consolidated to the Grimsby site, and just to remind people what that means is that medical patients will still be received onto the Scunthorpe site and will be kept where appropriate for up to 72 hours within reach from cardiology, respiratory and gastroenterology. But if they need subsequent ongoing inpatient care, then at that point would be transferred. And finally, for our paediatric patients, the suggestion was that the overnight inpatient care would be consolidated to Grimsby, but following the consultation and a lot of discussion, it was determined that it would be appropriate at this stage to retain the inpatient beds on both sides, but work very much towards the hospital at home model. So, because what we heard particularly from children and their families was that they would far prefer to be dealt with within their own home where safe and appropriate. And so we need to work towards that as our principal model of care. And so we'll retain the paediatric overnight beds as they are. Thank you. And like I say, I'm happy to take further detailed questions after. Alex.
Thank you, Kate. I'd just like to drill a little bit more into the transport impacts and mitigations, because as you heard, this is one of the key pieces of feedback that we heard through our consultation process as well. So just touching first on the statutory transport impacts and the ambulance impacts, which was one of the issues that we had feedback on. You can see here we've quantified the impact. So if we look at the overarching changes here, that's around 3 patients per week that will be expected to be diverted to a different trauma unit, and around 1 a day where there will be a blue light transfer between hospital sites. And given the reduced scale of this impact, under the changes that we're proposing here, and extensive work that we've done with the ambulance service to understand capacity and demand in this regard, we do not think that there'll be any significant impact on performance as well. So close working to model the absolute impacts and make sure that that can be delivered within the resources that are available as well. If we move on to some of the inter-hospital transfers that will result from what Kate has outlined in terms of the proposed changes, here we've got around 5 patients a day that would be expected to transfer between sites as a result of the changes. If you look at the totalities, because as Kate highlighted, we do have shifts in the opposite direction for some services as well, it's around 8 patients today. The proposal around this is that we do already have a number of inter-hospital transfer solutions. We think there is a more effective way of delivering that within the existing resource envelope. So there is a plan to do a re-procurement of existing inter-hospital transfer to be able to deliver a more efficient service that we're confident will be able to manage the numbers that we've identified within all the modelling work that we've done. Just in terms of the feedback that we receive from people and their families about how we support people to be able to continue to support and visit people while they're in hospital as well. Again, we've done some work modelling the impact, not just on people, but on those additional visitor journeys as well. Very important element of the feedback that we've received. So we think around 22%. 22 additional journeys will be required per day. If you then look at car ownership versus those people who don't have access to that, and look at that in terms of public transport and other transport opportunities, that impacts around 4 journeys per day. Just picking up the point about inequalities that Lindsay made, that could disproportionately impact on some of those people who are least able to be able to access that support as well. And therefore there is a proposal within the decision-making business case that we would look at enhancing existing community transport provision to be able to support that element as well. We've got some good community transport solutions, and we've worked closely to look at how we could enhance that to enable us to support some of those visitor journeys as well to do that. Just a few supplementary points to pick up as well. There are other ways that we can support people around transport. We do already have an NHS reimbursement scheme for people who need to use transport. It isn't as quick and efficient as it should be for people in terms of being able to have that money repaid back to them. We've got work ongoing to look at enhancing that. There is more we can do around clinical scheduling to make sure that people are accessing appointments in the most appropriate place and that we're not having people to move across our patch. To do that, so there's a piece of work around clinical scheduling. And then there is a broader piece of work that is being looked at around public transport per se and what some of the opportunities might be to try and enhance that as well. My next and final slide is to talk about benefits, impacts and mitigation, some of which I've touched on. And it is really to draw the board back to those key benefits that we are seeking to achieve out of the recommendations that are being put forward and were originally put forward in terms of taking forward the consultation. So that is about looking at how we can support the delivery of 7-day services across clinical standards, how we can look at reduced length of stay and improve clinical outcomes for people through these recommendations. It enables us to look at improving theatre productivity and a reduced impact on electives, so some wider benefits from the proposals that we're looking at. Looks at how we improve efficiency through consolidating specialist teams, resource and equipment, improving recruitment and retention, which you know is one of the key challenges that has taken us into this consultation, by looking at more attractive roles and opportunities for clinical staff, and looking at how we enhance opportunities for learning and skills development. And then just to give a quick summary in terms of impact, as Kate said, 7 patients per day would be impacted overall by the recommendations within the change. Extensive modelling has been done to make sure there is bed capacity to be able to support that. So you can see there is a net impact of 36 beds, increase at Grimsby and decrease at Scunthorpe to make sure we have the capacity to support that. Capital costs to enable us to deliver the change are 9.2 million. This is included within the Trust's existing capital plan, so there is no additional capital sought on top of the capital plan. We believe the changes will deliver a revenue saving of around 4 million, but they will provide a platform for further revenue savings because it will enhance the ability to deliver productivity by delivering this model, and it will help, therefore, to accelerate future service change as well. So those are the key points that I think we wanted to pick up, and we're happy to take any questions.
Thank you very much. Very, very concise presentations. Brilliant, well done. Teresa, I think, has a question.
Yeah, so a question and a comment, if you don't mind. Firstly, so I absolutely support these proposals, but obviously from a patient safety perspective, I support these proposals. So thank you, Alex, for picking up the transport issue, because I noted in the business case that it was identified as a negative risk, unmitigated, the transport issue, the patient safety concerns with delays to transport. So with all that you've described about the work around transport and the changes, so it's now 7 patients, not 14, to what extent is that now a mitigated risk? Is it fully mitigated, or?
Yeah, indeed. So we feel by looking at understanding the impact on all the work that we've done with ambulance providers, that's a mitigated impact, so that is manageable within the existing resource that is available. If we look at the wider issues in terms of having relatives able to visit that, the proposal that we're putting forward is that we put additional capacity into community transport solutions. We looked at a range of options to how we would do that, and we did a full options appraisal to understand that. That was the preferred option to be able to support that as well, because we absolutely recognise there are impacts for people visiting as well. So I think it provides a mitigation plan for the issues that we've identified in consultation.
Okay, thank you. I'm happy to save my comment until wrapping up. Okay.
Stuart.
So thanks for that. I'd like some sort of assurance on quality. On the PDF 6, the one that showed where we'd originally proposed to put things and then where we've ended up putting things. So I was under the impression, and I'm no medic, so I was under the impression that consolidating all of these things into one place would give better outcomes. And in a couple of instances that you've highlighted, we're not doing that, although in both of them there's future actions to take. So is there any sacrifice of quality by leaving it that way as opposed to consolidating to one site?
So our surgical pathways, when we originally started the consultation, we put surgery in a big bucket. And actually, as we started working through things and discussing with each of the specialties, the determination was that actually putting them all into a single bucket wasn't the right thing to do, given the estate that we have and the workforce that we have and the resources that we have. Yep. So essentially, if you put all of it, emergency surgery into that one single bucket and shifted it in its entirety, and when I say surgery, our general surgeons, colorectal and upper gastrointestinal surgeons, think of themselves as surgeons, but we were talking about orthopaedics, ENT, urology. So as we started working through the pathways, there was an absolute recognition that actually we would be far better looking at ENT as a box, urology as a box, and work through them, and gynecology as separate boxes.
Pick up the last one, gynecology is on both sites.
Yes, that's correct.
As opposed to one site, whichever way it had gone. And that I'm just confused by that. I thought one site was a better answer than two sites, for all sorts of reasons, staffing reasons and all sorts of reasons. So,
shall I pick up gynecology specifically?
And paediatrics has got a separation rather than a one-site thing going on.
So gynecology has a distinct, close interrelationship with obstetrics, and obstetrics maternity services was not part of this consultation. And our obstetricians work jointly as obstetricians and gynecologists. So in an on-call, that's correct. So out of hours, after 5 o'clock at night, there is a single consultant, a single team that covers both the obstetric and the gynecology service. Right. And so therefore, by suggesting that we would consolidate all of gynecology onto one site, we would still be providing an obstetric service on the other site. So we'd still have obstetrics on one site.
They need a team on both sides.
And you'd have to have your team on both sites.
You've implied there might be a consultation in future on this topic.
As with everything, it's really important that we always look and reconsider all of our services, and that's something that we do on a general basis. And you would expect no less of us to do that. So that's the gynecology. Paediatrics. Similar sort of discussion, but as you can see, that not just was there a clinician feedback that we needed to maintain neonatal intensive care units on both of our sites, because we continue to provide that obstetric service as well. And when you have your obstetric service, you need to have a neonatal service as well. And so from a staffing perspective, we were going to need to continue both. And actually, the model that we should be looking at and should be developing is a hospital at home. And the best way to do that is through maintaining our inpatient bed base, having that as our secure comfort blanket, as it were, whilst we develop a better hospital at home model.
So if I might summarise, this is a higher quality result than perhaps the original proposal would have given us, or at least the same quality in an outcome sense.
I think that the quality of outcome that has been developed is I can't think of the right words. I think that the consultation has shown that there are always other options that are available, and that we have listened to those options and feel that they are more right than the ones that were originally proposed.
Thanks, Kate. Do you want to come in, Stephen?
Well, only just to press the point a bit, Kate, because I think to really put it in a very straightforward way, have we lost any quality benefits by having, which is really the thrust of what Stuart's asking, by having, and we all understand, I think, the relationship between maternity and, but emergency surgery might be a different matter in terms of critical mass and all of that. So that, I think the question was, what's the status of quality given the adjustments? Have we lost any quality benefit?
I don't believe so.
Right. Thank you.
Thank you. Mark, Jonathan, Teresa.
Thanks, Sue. Thank you for the presentation. Thank you for the slide pack. I found that very helpful in terms of understanding the consultation process, and I think particularly listening to the feedback and how that's affected the final proposal, as it were. I've got a question which is related to both the consultation and how we might go forward to communicate any decision, depending on what the decision is. And when I look at the benefits, and I just picked up on Stuart's point to an extent, clearly one of the main drivers of this is quality of care for patients. Is your sense that in the consultation process that people understood that this was primarily, I mean, it's about other things, but it was about quality of care, the best possible care for patients, as opposed to it being about other factors? And I think particularly in the context of the fact that, you've said there's like 7 patients a day are affected, which might not have been intuitively what people might have thought. Do you think that's been understood, and have we got a plan that how we might communicate that aspect going forward?
Thanks. It's a really good question, if I may pick that up. I think yes and no is the short answer. One of the things that we found through the consultation, and I think continues, and you can read this in the feedback report because it's been quite well documented, there are a lot of concerns that people raised around sort of misconceptions, thinking that the emergency department was going to close, or that every single patient for every single cardiology, anything, would have to go to Grimsby. And I think when we were able to take the time to talk to people through the consultation, they really did understand that. And actually, the more opportunities that we had to have conversations, whether that was in the Christmas market at Scunthorpe or any other cold venue that we found, or and people were willing to engage, actually really willing and really receptive to sort of taking that on board. There are obviously wider issues in terms of how things are replayed, and there is a comprehensive communications plan will sit with that implementation piece, and it will be really important for us to continue to provide those reassurances and to do it in the right way that says Scunthorpe still has an emergency department, but don't come unless you really need to, because we don't want to promote it, but equally we want people to understand. A lot of it will come through how things are experienced by people on the ground day to day, and actually it will take time, but we have made sure that we will do that communications piece, because it is really important that people are reassured that it isn't every single service, but actually we're talking about the highly specialist stuff, and that we will sort of make sure that people get to the place that they need to get to for that.
Thank you. Jonathan.
Yeah, I'd just like to say, I mean, a great amount of effort gone into the consultation, etc. But we are talking about the here and now, and you know the best thing. I'm just wondering how much consideration is being given to the demographic changes over the next few years, particularly that post-75 growing elderly population. How much consideration is being given to that, about some of those mitigations moving forward?
Well, I think it's quite, so we did quite a detailed piece of work, and there's some information in the DMBC around the impact assessment, integrated impact assessment, and we did actually also look at the age stratification around the impacted patients, and what you actually start to see is that the changes, the proposed changes, have a disproportionate impact on younger adults rather than older ones, and part of the reason around that is because in developing the proposal, one of the early suggestions that was looked at was around care of the elderly, general medical beds, but actually the proposal is to retain them in Scunthorpe and to put in place as many pathways as possible so that people with frailty, people who are older, actually we do much more to keep them out of hospital at all. If they need to be in hospital, wherever possible, we'll care for them in that general medical environment, so that they are close to home and we're not taking people unnecessarily to other sites. In terms of the modelling, it looks at the sort of detailed modelling piece, used the ONS population projections and future demand, so that is all put into the detailed modelling. But yeah, there was a definite effort to ensure that the impacts were not going to be disproportionate on that older population.
Just to briefly add as well, we've done a parallel piece of work because we're looking outside of the hospital, as Lindsay's alluded to make sure that we've got the right services, but also we're really pursuing our ambition about care closer to the home. How do we support people? So for all of the areas that we are recommending change, we've looked at how do we support people in an out of hospital environment, and we've done a similar piece of modelling to try and understand how we do that. So a tangible example of that is the paediatric hospital at home model, but we've done that across pathways, including frailty, for example, looking at the medical specialties. So just to cite that additional piece of work of how do we make sure that our out-of-hospital services are able to respond to the impacts of the recommended changes.
Thank you. So it's Jane, then Teresa.
Thank you, Chair. I fully support this proposal, so thank you for the presentation. I know how long you've been on this journey, having experienced a little bit of it myself. My question's really around the staffing piece that you've raised. So I know you've had feedback around career progression. I can see what you put on the slide here, and I can see the narrative that you've put in the how we've responded. You said we did. Have you mitigated then the risks that you might have through quality, through staffing, as in full rotas and the way that you've done your recruitment and retention?
Do you want me to?
So thank you, Jane, for the question. And I think that, as you are all aware, staffing across the NHS is challenged at the best of times, not just unique to this area. This area is additionally challenged, and we are going to need to continue looking at recruitment and retention initiatives. So the position that we are in today is very difficult. The changes that we're making, we will need to wait and see, to be honest. But by making our services more resilient, it fits with the feedback that we had received, that people feel that when they're on their own in a specialty, they feel very nervous and would prefer to work in a bigger centre where there are more people with those specialist skills around them, regardless of what specialty they're in or regardless of what clinical professional background they have. So by providing the consolidation of the services, we are actually answering one of the many queries, concerns that have been raised by our teams. So you asked the question, do we feel it's fully mitigated? We have answered what has been raised as a concern, but it remains to be seen whether it will work out. And that's my honest answer, Jane. I would love to say that everything will be great, but I can't say that.
Yeah, thanks.
So Teresa, Nigel, Emma, and then Peter. It's Teresa.
Thank you. I just want to come back to Stuart's point and the point he raised in relation to the changes that have been made, and is this now, better from a patient safety perspective or not? And I just want to give my take on it, so you can tell me if I've got this right or wrong. Okay. So my take on this is that actually the proposals now better fit for the scope of services that are now included as part of the consultation. Because for me it links to the other comment that Kate made around the need to continually review clinical sustainability of services that we will need to do across the whole of the ICB, and that will include services that are provided at NLAG at both sites.
Thank you, Teresa. Agreed.
Emma.
Thank you, Chair. And yeah, again, fantastic to see this after so many years coming to a decision point. Just in terms of the money and particularly the revenue impact, you would expect me to comment on that, I'm sure. Obviously, the business case is quite a traditionally based business case, and so I understand the complexities of building a do-nothing model on which to compare the revenue savings, but I do feel I need to just draw to the board's attention that obviously the net savings is on an increased baseline level, which obviously is clear to see within the business case, and obviously the description of the words around the affordability of that is that it's going to release productivity and efficiency that then is going to mean we can achieve greater levels of elective recovery funds. So it's not a problem, but I think it's worth just drawing everybody's attention to that, and obviously connecting it back to the conversation we just had around the design for the future, working as a system on a medium-term financial plan. We are going to do something, not do nothing in that context. And so, again, just around how we're using our resources and prioritising our resources going forward, I think it's worth highlighting.
Could I just, I would have come out of this, but just can I just be clear so I understand? Because my question was, because I've asked this question every time, was how assured, I'm probably asking Alex actually, are we assured that 4.4 million is being released? So
yeah, but I'd describe by Emma on that increased baseline. But as you've also rightly, which is the model that we've always used, we consistently used through the business case. What this does, and I appreciate in the general context that's relatively moderate saving. However, what it does do is it gives us the baseline to be able to deliver some of the other work that is consistently going forward in relation to this. So there are more
really
opportunities.
Clear, I'm saying we've released the 4.4 million, or will do, as a result of implementing this plan.
Yeah.
I think important to obviously reinforce that this was never a financially driven process.
I'm completely aware of that, and then hence waiting until we got to this point.
Indeed.
However, it is ordinarily the case in public consultations that there is an expectation, there is an efficiency gain or an improvement or a financial gain. So just
indeed.
looking for assurance that that will be.
Yeah, we can provide that assurance. Yeah.
And Nigel, you said what you wanted to say, didn't you, Peter? No, you haven't. As it must be you.
I fully support this, and I was just wondering whether our clinical colleagues across the acute sector and primary care agree with it as well, and what consultation you've had with them, and what your colleagues within the hospitals.
Thank you, Nigel. So, the public consultation, we were very clear, was for every member of the population, and therefore was for internal and external to the organisation. And we had numerous, multiple focus groups of all staff groups and all specialty groups. And as you will expect, and as you'll have read in the consultation, in the feedback, there are different views that are taken into consideration and different weightings given to those views. There are some individuals that do not agree with what is in the proposal, but that is to be expected, and not just from clinicians but from our members of the general public. But there are also people who wholeheartedly think that this is the right thing and why haven't we already done it, and that will always be the case. But we know that do nothing is not an option, and we are going to be doing something, and as you can see, we have responded to the feedback that's been received and made suggested changes as a direct result of that. So that's my secondary care answer. From a primary care, it's essentially the same, that some think it's great, why haven't we done it? Others not so keen. But as we go through the communications of this and as we start working through the pathways, that will be when we have a better opportunity to show the benefits to the quality of care delivered for our patients and support our staff in building those resilient services for the future.
Thank you. And very finally, Peter.
Thank you for the presentation. I think it's also important to note that the board has had all of the detailed responses as well, including the 200-page report from the opinion research services summarising the feedback. Within the depth of that detail, a very small minority of respondents did question the integrity of the consultation process. So perhaps to end, Chair, can we have a bit more about the assurance that the consultation process has been robust, particularly if there has been external validation of that?
Sure, I think probably another one for me. Thanks, Pete. Yeah, and as you say, it's documented quite clearly in that ORS report. One of the things we did throughout the consultation, so prior to launching, we worked with the Consultation Institute through their 6-step quality assurance process, and it's quite a robust process, and it's quite taxing. They don't give out the Good Practice Awards lightly. But what they do is they reviewed our consultation plan and provided feedback on that, and we made changes to the plan before launching. And then during the consultation, we held a midpoint review at about week 6 or 7. And that was a 3-stage review. We did a piece with internally with colleagues, then we did a review with NHS England, and then with the Consultation Institute. And based on that midpoint review, we made changes to the planned proposal of activities. So we added additional activities in that hadn't previously been on the plan, whether that was to visit different locations or to target different populations. We also did some additional work in terms of the paid for social media advertising, which was very successful in terms of driving people to the information. Whether they chose to respond or not was obviously up to them. But again, that piece of work was quite well targeted. And then additionally, we did a leaflet drop. So we had the summary leaflets about the consultation, which we arranged for them to be distributed in areas where we had less of a return, and also cross-reference that with areas where there's a higher level of digital exclusion. So people who might not have access to the information online got a paper copy through the letterbox. So at each of those stages, we responded to the things where people had given criticism. The criticisms we had around how the events were hosted. For example, the Scunthorpe initial exhibition was on a particularly stormy day, and we were criticised for the bad weather, which is clearly within our control, obviously. But we did respond to that, and we hosted a further, I think, 3 events, including the one at the Christmas market, which actually was probably one of our most successful, because we got people who were there not coming to see us, but out doing the Christmas shopping. So we did sort of respond to those and make changes to the consultation. And then the Consultation Institute did the final stages of assurance, which takes you right through to the feedback report. So they reviewed draft copies of that and made comments, and ORS made further changes based on that feedback. So there was 6 steps to that process before they gave out their tick.
So in summary, the board can be assured that we have met and gone beyond the statutory requirements.
Sorry, that would have been the short answer. So yes, yes.
Thank you. Thank the board very much for the interest in this. We've been following this for quite some time, and thank you 3 very much indeed for your contributions today. It is now for the board to make the decision, and I've got some clear wording here that I'm going to just make sure I get right. So the board's asked to endorse the proposed way forward for service change, which has been developed following the review and consultation, and takes account of those issues raised in the consultation. Many of you began by saying, I support this. So can I just check around the table? Does the board support this proposal looking ahead?
Yep.
Yes.
Yes. I think that's unanimous support to go ahead. And there is a second thing for the board to agree to, which says, can the board agree to work with key partners to deliver the proposed transport action plan, including increasing support to the existing community transport provider? So you can see that patient transport is a significant issue in terms of this change, but many other changes too. So can I just double check the board is happy to go along with that?
Agreed.
Yes, we're agreed. So thank you very much indeed. Your proposal has been accepted, and I expect you've got more work to do this afternoon as a result.
Thank you very much.
Thank you very much. Thank you. Okay, board. Let's return to Plan A, which is agenda item number 13. I think we anticipated that this might be a long agenda item. Actually, it doesn't have to be, because people are very well cited on this urgent and emergency care issue. We wanted to bring it to board for specific discussion, because it is very, very high on our worry list. It's an area where we're an outlier regionally, and it's an area where we know there's risk in relation to patients and service users. So we just wanted to give the board the opportunity to understand a little bit more deeply the performance challenges that we face, and to take some assurance from the oversight and the work that's going on in an endeavour to improve that situation. I think you all know it's hugely high profile in the media. It's hugely high profile with politicians. So it's something that the board absolutely need to be cited on as well as possible, and perhaps something we might want to track in a different kind of way, Stephen. Stephen had some very interesting slides with some very interesting facts as part of them, and I think he's going to share those with you.
They're in the pack. I don't have a presentation.
They're in the
pack. So I'm briefed. And just to, so you've set that up. I wouldn't say much more, but I think it's probably just also making the point, more generally, this is a significant test to the ability of this system to transform and change urgently. So I think when I'm going to hand over to Jane and to Teresa, I think, in a moment or two, and I think the focus needs to be on what we're actually doing, as opposed to an analysis of the challenge. So that's the focus I would expect us to be talking about. But just to elaborate on what you say, I think it's important we record this. The last 2 years, performance has barely improved in the emergency care pathway against all the measures. With the important caveat that HDFD do better than our other acute organisations. No trust has delivered their plan, but this isn't just about the trusts, nor have we actually delivered very effectively the out-of-hospital elements of this agenda, despite multi-million capital and revenue spent. So that just puts into context what you've said. So really, in terms of, fundamentally providing high quality services to our communities and our patients, there's an urgent need for change, but I think an urgent need for change that is about sustainability and actually responds to what we were talking about at the beginning of the meeting around services being provided in the most appropriate place, particularly for our elderly frail, the 91-year-old man or woman who really shouldn't be in an emergency department. They should be in the Jean Bishop Centre or at home or in another supported environment. So I don't want to say more than that. I think that's why it's here. The only one other thing I do want to say is back to the role of this board. This board is accountable in overall terms for the system performance, but clearly the accountability for delivery lies with our providers in every sector, not just the hospitals, in every sector. So anyway, with that I'm going to hand over to Jane.
Jane.
Yeah, thanks. So in response, we've had urgent emergency care pressures, and in the paper you've got an extract of data which is in June, so a particular difficult performance in June. And we called an urgent care summit that Stephen chaired on the 13th of July. And so, just for people's information, there's an urgent and emergency care recovery plan published by NHS England, and each of our systems are responding to that. But what we've tried to do is refocus on the things that would make the biggest difference. So we've had GERF, we've had ESIS, we've had lots of external support, and they've come up with, so we summarised 4 specific actions that would make the biggest difference. And we wrote, following the summit, we spoke about these 4 actions. So one is, I'll just briefly talk about it, one is specially input to ED, surgical pathways so that SDECs are working better, removing the need for going through ED department, internal professional standards to fully embed and ensure UEC ownership across the trusts, and then some direct access to ED with alternatives. There's a little bit more detail under each of those 4 actions. And then we also agreed that each of the systems, if you like, would come up with an action which would undertake 4 actions. One was that each UEC board working with YAS, acute trust place directors, agree a recovery plan that would need to be completed by the 12th of July, so that's due on the 12th. Nigel and Teresa, and I'm going to hand over to Nigel and Teresa in a minute, would coordinate some work with clinical leadership, because this isn't just about performance. We thought this is about cultural ownership of this problem across the whole organisation, particularly that clinical leadership is really, really key on this. So Nigel and Teresa have committed to that. Each organisation is committed to ensuring senior decision makers attend both the local UEC boards and system UEC board. I'll come on to that in a minute. And that each local UEC board to set out their governance in terms of how they work. So how the governance works, we've got a system-wide UEC board and we have 3 place-based UEC boards. And what we're finding is that the 3 place-based ones, first of all, they're not I think the North Yorkshire one at the moment only meets quarterly, so it's that people attending and ownership of the problem and getting the right representation and undertaking the correct action, so that there's that bit. So we've asked for a map of the governance of each of those UEC boards, and then we've got the system-wide. So this isn't a quick fix. We've been going at this for years. We know what it is to be. We know what the impacts and the interventions are. It's trying to do that in a sustainable way, and also this is a focus for the whole organisation. It isn't ED. It's about system-wide response. So we've organised a clinical summit and then also a system-wide summit with other partners, and that is in about 2 weeks' time. So there's lots of things we're doing. Interestingly, performance has improved since then, and Sean sent Stephen and I a little bit of a snapshot of how things have improved. But this, at the end of the day, this isn't about metrics. This is about patients. And the thing that we're particularly bothered about is some of the ambulance handover delays and the impact. And we talked about, it's not the risk of the patients that sat in an ambulance outside ED, it's the patients that they can't pick up within the system.
If I could just say, Jane, and you're absolutely right, the performance has improved, but then the pattern of last 2 years is about sustainability. The pattern of last 2 years is, it does improve, but the overall picture is not one of improvement. So, and then your point about, absolutely, it's complicated for all sorts of reasons, a complex challenge, but our expectation ought to be to see a steady pattern of improvement if those things you describe properly implemented. And I think that's the thing we really need to have confidence about over the next few months.
And I think that there are things that we can do. So Stephen, you attended the last UEC board, which we did last week, and one of the examples is, in one of our places they had something like 60 points of entry for urgent and emergency care services with that, and we need to have a single point of an SPA, a SPOC, a single point of access, which we do need to do those. But what we're finding is that some of those actions, those multitude of actions, if they're not really working, they're not visible and they're not being used, we just need to stop them. This is about doing the things that matter. So there's lots of things that we can do, but it requires not just the hospital response, but social care and our place-based teams and our place-based teams working together. So there's lots and lots of work going on, and then there is also, just for people's information, a dialogue with NHS England about something called a tiering. So each individual provider is measured against, and I think it's in the paper about the metrics, and we're currently mostly in tier 2, but we are now looking at those metrics and working with NHS England, and that would have implications of how this is performance managed and the ICB's performance managed going forward. So we're on that cusp of trying to stay in tier 2 and not be escalated into tier 1. But I'll hand over to, I think, Teresa and Nigel about the clinical summit that has been organised.
Yeah, so background to this really is that as part of the discussions, I think there's concern really, and we've mentioned it at this board before, about the potential really of normalising poor and unacceptable standards of care just because of the continuous pressure that staff are working within. So there's allied to that, I think there's concern that there's a loss of operational grip and a loss of understanding of what actually truly impacts patient flow through the hospital. And at the moment, what we're looking at are the culture and relationships within the hospital. So we know all the, we need to stop patients arriving at A&E, and we need to get patients out. And the patients out bit is equally important, I think, as part of the focus on relationships. So there's a number of facets of this. So there's the relationship, as you mentioned, in terms of the specialty team, so specialty input into ED, but also the decision making and who can authorise patients going where and to what specialties. So some of that simplification of where patients can move to it is a feature. One of the things that we are looking at is in terms of easing discharge, particularly for pathway 1 and pathway 0 and pathway 1 patients, is criteria-led discharge, where we don't have to wait for a consultant ward round, for example, for a patient to be discharged if there's clear criteria set for a patient's discharge in advance. We've had some work, as I raised this some months back, and we had Aqua commissioned to look at criteria-led discharge and barriers, and the focus of the work was at the Hull site. And we'll be using that report to work with the clinical teams, because one of the biggest barriers is actually adoption of the principles of that by the clinical teams. So that's the approach that we're taking on the 15th of August, is that clinical workshop. I think the other thing to say is that I know from a performance perspective, yes, there's the focus on the ambulance handovers, but the biggest focus is around the 4-hour target. And clearly, nobody wants to wait 4 hours. They don't actually have to wait. There's not really usually a great benefit from waiting to be treated. But from a patient safety and patient harm perspective, one of the areas that we need to target is actually the 12-hour waits in ED, because we know the evidence base is that we've got increased mortality and morbidity with every hour that patients are waiting in the ED.
Thank you, Teresa. Nigel?
And just to add, alongside that clinical summit, so this Friday the clinical professional group will start to see those plans that we talked about, and also talk about the wider clinical input that's needed from the system around that, and absolutely picking up Teresa's point on clinical culture within and outside of hospitals. Sometimes EDs look like it's an island, and it's everybody else's problem. So it's everybody's problem. This needs to be done. We need to be reaching from specialties into that. We need to be streamlining our aspects, as Teresa said, and we also need to look at the single points of contact for the pathways in, because that was coming across that it was highly complex and complicated. So people were getting into the wrong places, and that drives poor quality outcomes.
Thank you. Okay, Bushra.
Building on that really, Nigel, I wanted to ask how primary care is being involved in the clinical summits. I want us to be absolutely clear that primary care is delivering and delivering above target in terms of providing more and more appointments and providing those appointments within the 14 days. But there is definitely a part to play at that interface between primary care and urgent and emergency care, and I'm sure practices and PCNs would want to be able to support this work through the use of their care navigation teams and the messages that we're giving to patients. So it would be good if clinical leaders were involved in that at an early stage.
Yeah, so we need to think about that in terms of where they input, particularly through the local UEC boards. At the moment, Bushra, but we can reflect on this. The summit on the 15th is about the in-hospital culture and relationships between the clinical teams. So I'm not suggesting that it's not important, because it clearly is, but it's quite focused around that at the moment.
Richard.
Hi. It's not a silver bullet, but are we doing enough with the digital solutions around this? Because I'm aware that there's a number of smaller fragmented solutions that are used not particularly well, I think across the region. There's things that have been put in place for winter pressures and now been taken away, like EDI, direct booking into different settings. There's other tools like Directory of Services and Pathways that are used by colleagues in YAS, but not necessarily in a cohesive way. So it feels to me there's a degree of fragmentation and lack of adoption around some of these things. Could we do more on that?
Well, I think that's what we're trying to do in terms of that consolidation. You know, so, one of the places they talked about something like 60 different pathways, but I don't think they're visible on the DOS, etc. And I know as well, I think in Scarborough there's only one alternative to hospital on the DOS. So there's absolutely work, Richard, that we need to do. First of all, it's consolidation, the things that work. Because I think anyone would say, well, if an ambulance, paramedic looked and there were 60 different that it just isn't right. And I know we're trying to create single SPAs or spots, whatever we want to call it, in terms of a single point of access, so that then people are then triaged. But 60 it's just far too many. It just doesn't make sense, does it? And I think what we've got is we've got to build up over time, haven't we, of these things, and they need an absolute rationalisation. But they enable the technician, particularly from an ambulance, and the conveyance in terms of the patients to the right place is absolutely fundamental. And I think that's the point in terms of some of the long waits in ambulances is the acuity of patients. So one of the feedbacks of one of the meetings was where we do safety rounds and all those patients are safe. I said, well, that might be the case. It's not the patients that you can see, it's the patients that are not getting access to the ambulance. It's that kind of thing, it's that system view. But we know a lot of the solutions, but there's still, for some reason, it's that sustainability. But I think we've got to challenge ourselves a little bit. And we've gone from 6 places, and it's about how do we create sort of like more consistency in offer, but using those solutions that you just described from a technical perspective and digital, definitely.
Thank you. Stuart.
I'm wondering if there's a sort of inequalities angle to the way that we look at this. So if there are particular groups who are disproportionately affected, or I'm looking at the background slide which gives the different stats for the different providers, where I think it looks like the worst performer and Harrogate looks like the best performer, and just wondering whether that's got inequality messages in it as opposed to just pure performance.
Well, the short answer is yes, because the level of
and therefore
disease and illness in the respective community differs quite significantly.
So how are we prioritising?
Not necessarily the level of elderly
based on
people, but
dealing with inequality.
proportionately.
Yeah, so I think it was at the Quality Committee, wasn't it, that Yaz shared a paper on inequalities in relation to areas of deprivation and the links with the rate of ambulance call out and responses. And that's something that we're picking up. It's the first time that's been done and presented to us in that way, so we'll be picking that up as a, so what now? Because there are potentially other things that we can do in relation to that information.
Jonathan, final comment.
Thanks. Yeah, I think, again, Jane, your point around focus is really, really important, because I think we're trying to do too much and not too much into it, and we try and set thousands of flowers blooming instead of focusing on things. So getting the local place boards to focus on a few things that will deliver and understand where the big impacts are. From my perspective and from a provider perspective, there's stuff that absolutely the ED can do to improve. There's things that the organisation can do to improve, and then there's stuff outside of the hospital that can improve. And again, we do need to engage social care, but let's not use that as an excuse. 75% of people who turn up to the emergency department do not get admitted, don't need a bed. Therefore, yes, there might be bed pressures, which we might need some help with, but the first 75% of people that turn up do not need to be admitted. So that's all within the gift of the NHS, and particularly the emergency department and the hospital that they're in. So we must make sure that we keep that focus, and that can only be done by my organisation, Simon Morris organisation, etc., to sort that bit out, and then we build from there. I think we've had lots of capital investment, we've got lots of staff, we've got lots of different pathways. As Stephen said, they haven't shown consistent improvement, and I think it is around a lot around the culture and the attitude and how we can improve things, and turning that round has got to be focus of attention in terms of how people take ownership of the issue and resolve the issue.
Agree.
And we will get to a tipping point, and we need to celebrate good practice sometimes when there is less work to do if you do better. The problem with emergency departments at the moment, they're a bottleneck. You need more staff because we're failing. If we're improving, the work becomes easier, and it's being able to demonstrate that and hang on to that. That's how it becomes. That's how it becomes sustainable. But we've got to put focus on 2 or 3 things and keep going on those things for a period of weeks, months, to make sure they deliver. And whilst the whole system is accountable, we mustn't use the whole system as something to hide behind and say it's somebody else's issue to solve, because there's, as I say, the stuff that the department can do, the organisation can do, before we even look outside of that.
Can I just say one final thing? One I think is using the data to dissect the problem. So you're issuing that whole. So Karina's team are looking at this, but we've looked at this, by day, by hour, the type of patients, the postcode with which they arrive, where they live. And what you'll find is that in terms of the whole example is that the locality around it will use that acute trust as primary care, because they can just walk there and get in. And the people that sit around those and live around those hospital sites are usually in the most deprived communities. And you'll find that in any typical hospital that's in those type of localities. So I've done exactly that analysis at the previous systems that I've worked in, and it's getting underneath that data, because then you can, once you understand who is attending, why they're attending, when they're attending, and not Jonathan's point that they don't need admitting, what are the solutions for those people? And it's multifaceted, but using that data in that really intelligent way that enables you to come up with some of the solutions, and that's what Karina's team are helping us on at the moment. And the trust will be doing this. They were looking at all those patterns, but some of it is it's similar across the country in terms of its access, some of that stuff.
Finally, Teresa.
Yes, final comment. Sorry, I have to say this. So in everything that we've said, I think this is genuinely about leadership, because there's a really clear message I would want to give, and that is that we absolutely recognise how hard it is working in these ED departments at the moment, and staff turning up day in, day out, and actually suffering trauma themselves as a consequence of some of their situation that they're having to work with. So I wouldn't want that to be perceived as any sort of criticism of the staff on the front line in that way.
Okay. We decided that we would look particularly at urgent and emergency care today for 4 reasons. 1, because we recognise it to be a really significant risk. 2, because of the really eye-catching data that's included in this pack, which shows us to be an absolute outlier. Third, because I think most of us will have watched the Dispatches programme televised over the course of the last month, in which many of the clinicians said you could probably see something like this in most trusts. And finally, because we received a letter from Sarah Jane Marsh, from Dr Emily Lawson, from Dame Ruth May and from Professor Stephen Powis, with particular requests for the way in which our board address emergency department. We're asking every board across the NHS to assure themselves that they're working with system partners to do all that they can to provide alternatives and to maximise in-hospital flow. And we have to be assured from our colleagues that that's happening, and I think today has fulfilled some of that purpose. I think we need to be watching really sharply for trends and how that's moving. For those of us who've done these sorts of jobs for a while, Ned's in particular, when I first began in the NHS, there were, summer was a walk in the park, wasn't it, for emergency departments, quiet hospitals, quiet emergency departments, and everyone was a little bit anxious about the winter. This is winter already, isn't it? And this is July, where we'd expect July and August to be the times where we're least busy. So thank you for your time. It was an important conversation to have, and it's something that I think I encourage you all to keep a close eye on in terms of performance reports, and let's just see if that trend starts to improve. So thank you. Back to the agenda. We're now going to move to item 14. And 14 was the follow-up on our various committees of the board. Now, I suspect we can move through this relatively quickly. I'm going to go to committee chairs or executive leads as we go along. So the summary reports begin with the REMCOM. Mark, no alerts to escalate to the board, but 3 matters to update the board on. Is that Mark or Jane?
Well, shall I just try and do this in a really concise way?
Yes, please.
We have a paper in the pack that highlights what we discussed in the Remuneration Committee, which I'm sure people have looked at, but I'm happy to talk through it. If you would like to raise any questions or issues, I'd be happy to take them.
Very nicely done. Any issues for Mark? Thank you. Thank you, Mark. On to the Workforce Board. Again, no alerts, 4 matters to raise. Jane, Jason?
Can I jump in? Because
of course you can.
3 really important.
Yeah.
So in the actual reports, we give you the links to what's gone on in the Workforce Board itself. So you'll have seen the detail of it. But there's 3 things that I wanted to raise that I think are really important. Okay. One is, you will remember that we were setting up the Inclusion Assembly across our system. And at the last meeting, we actually agreed the purpose, the vision, the values and the work plan for that assembly. Now that's been a year in the making. That's taken quite a lot of work and a lot of development to get to that point. The hard work starts now. I think, Bushra, you would concur with my view, but I think please have a look at that. There's a lot of information in there and it's worth you having a look at it. Also in there is the pay bill and agency management work plan, the link to the actual work plan, which I think is worth everybody having a look at if you haven't looked at it in detail. So that'll tell you what we're doing. And then the final bit is the people story, which has been really hard work. The people story is code for system workforce plan, really. And it's taken a lot of work to get to a point where we have a lot of information now and a proper system workforce plan. Still work to do, but a couple of headlines from there that I think is worth, and you might not have seen it because it's in the detail, but if we were going to reduce our workforce by 2%, we'd need to recruit 48,000 people across our system because of the turnover levels that we have. So, and if we were going to increase by 2%, that's 62,000 people. Now in the pack there is the detail breaking that down into role types and areas of work, but when we do talk about managing our pay bill and reducing our pay bill, we also have quite high turnover, and it's quite an interesting statistic, I think, to just point out to people. So that's all I was going to raise, Chair.
Yeah, retention is such an important thing, isn't it?
Yeah.
No comments. Audit Committee, Stuart.
Well, to state the obvious, we're quite busy looking at, and I know we've sort of said it already, but Emma and Karina's teams have done a fabulous job there. So just to say, again, The item that's on the agenda is forward-looking, so there's a new national system coming. That means we have to sort of take numbers out of one system and move on to another system. That creates a risk as far as an audit committee is concerned, so we're keeping an eye on that, which is what that's on.
Okay. And I think we delegated you approval to approve the accounts, didn't we?
Oh,
did you do all that? Just checking. Okay. Finance, Performance and Delivery Committee, Richard, who is learning all about that committee, aren't you, along with Emma and Jane?
Thank you. Yes, as you can see, just a couple of alerts. I think we've covered them probably earlier on in this meeting about sessions with colleagues across the system, both to make sure we're on top of the reporting during the year because of the challenges around efficiency and productivity, but also the session that was held with the chief exec and the chief execs and the directors of finance recently to kind of recommit to the achievement of those targets during the year that's happened over the last couple of weeks. So they're those.
Nothing further. The ICP, that's might be you, might it, or might it be me? We briefed the Integrated Care Partnership in the usual way, Jonathan and I. We co-chaired the meeting in the usual way, didn't we, Jonathan? And we've made a very big commitment at our September meeting to talk about patient transport. I think Jason's got some information that we can use. We can work with him. It clearly is quite an issue, but nothing more to raise, I don't think. They agreed the updated strategy plan, didn't they? So yeah, a good positive meeting. And then Nigel, Pharmaceutical Services Regulations Committee.
Yes, there was just two bits on this. I don't think this actually sits under me. This probably sits more under Q's director, but nothing particularly to
Okay, no, okay, all right. We don't usually whiz through that quite so quickly, do we? But actually, there were no big alerts, so I don't feel bad about doing that. Item 16, this is the Women Living Well programme, Anya. You can take the paper absolutely as read. What would you like to raise with us about that programme?
Thank you, Chair. And just to flag, it does say on the agenda that this is for approval. That's a mistake. Apologies for that. It should be for assurance. It's to provide the board with a brief update on the Women Living Well longer programme, which we've rebranded it from the Women's Health Hubs because it was causing a lot of confusion with people envisaging porta cabins in car parks delivering women's health services. There are some slides which I will just quickly whip through if that's okay, just to provide the board with an update. So I won't go back over the information that was provided last September in terms of the sort of seed funding, if you like, for this. But just to pull out a few key points, we have pulled together and used some of the funding to create a multidisciplinary programme team, most of which sits in Nigel's area and in other parts of the ICB. That team really came to fruition in April and since then have made substantial impact in developing our agenda in relation to, I will just say Women's Health Hub because in this context it's a little bit easier to understand. If we can just move through the slides, please. So to the next one, this just sets out the principles for our delivery of the programme, and you can see there a particular focus on reducing health inequalities and to deliver sustainable provision. You will have seen on the previous slide that the funding is relatively small and only lasts into the next financial year, so we have really focused on trying to create a model that is sustainable to benefit women and girls within Humber and North Yorkshire. If we can move on, please. So what our hub model looks like is completely different to said porta cabin in a car park. Extensive work has been happening to really think about how this is fully embedded in primary care. So 6 PCNs have been identified to become Women's Health Hub pilots, and each of those will appoint a Women's Health champion. We will use some of the funding that was received through the national route to deliver training for clinicians, and particularly in the first instance that is through the fitting of LARC, which for those not aware is a long acting reversible contraceptive and menopause. And we will also be piloting a multidisciplinary team to bring together primary and secondary care, and the focus through that programme for Humber and North Yorkshire in the immediacy will be around contraception, menopause and pelvic health. I should just point out, because it relates to the performance report that Jane brought to your attention earlier, that initially when this the hubs were launched, if you like, and the funding became available, it was very loose. There were no parameters. The ICBs could spend that money in any way they wanted. More recently, there have been some parameters that have come in through the performance route. So each ICB must deliver a hub by the end of this month that is delivering 2 core services, and by the end of December delivering all of the identified core services. So we are on track, and our first 3 will be around those areas. If we can just move on, please. I think it's really important that we just highlight some of the key challenges that we are facing. Again, I won't repeat what has been said earlier, that the whole rationale really for the Women's Health Strategy and the development of these pilot women's health hubs is because women do face disproportionately worse outcomes in terms of both service access and health outcomes as opposed to men. We've talked through that before and some of the evidence that sits behind the strategy. And I will just say that our BI team have done a fantastic job in developing a women's health dashboard for use by all stakeholders, so we can really drill into some of the issues relating to women's health, women's and girls' health in Humber and North Yorkshire. But we have just pulled out on this slide some of the key points that relate to why we've prioritised some of those areas that I've just outlined, so that you can see that that there's that disparity, particularly between some of our more affluent and deprived areas, as we see in other cases. But there are some particular points here in terms of the under 18 conception rate, so that's the pregnancy rate. You can see there the difference between Hull and York. The LARC that I've just talked about, you can see again the difference is there between our more advantaged and disadvantaged area, and you can also see here, and this is a national issue as well in terms of increasing abortion rates, but you can see again here some of the differences in those abortion rates. So this is really led to us putting a spotlight on some of those priority areas through this programme of work. And of course what is hugely important and has been hugely important and was set out in those principles is that we absolutely need to really understand what matters to women and girls in our area. Yes, we've now got a lot of really helpful data and we've got a lot of information from our clinical colleagues, but we need to overlay that with the more qualitative insight of what matters the most to people. And again, if we can move to the next slide, please. These are just some of the key findings from the engagement that has happened to date, and we are now doing more engagement around those 3 areas. But you can see here that there is significant demand for menopause care. But not all GPs feel as if they have the necessarily skills. They're not equipped to be able to support menopause care effectively, and equally that's also the feedback from women in particular, that there's a variation, let's say, in menopause care, and that came out in the national piece as well. Patchy access to contraception, and there's a belief particularly amongst our providers that the commissioning of LARCs is overly complex and complicates access for women, and again that is echoed by what we're hearing from women themselves, that it's very complicated. So the last slide, if we can just move to the last slide please, just summarises really the programme on a page. So we've got those 3 areas of sorry, if we can move on again. Thank you. We've got the 3 priority areas at the bottom that I've just outlined, and then these are the 3, the summary of the 3 activity streams that we are working on at present. So thank you, Chair. I appreciate that was a quick rattle through, but conscious through time of time, and I did just we did just want to provide board with an update because it is very important.
Okay, lovely. So Louise, Bushra, Jason, Peter, Jane.
Yeah. So Anya and I have connected outside of the meeting because we do have people in our local authority public health teams really interested in women's health and trying to lead on implementing the strategy. And of course, public health is a commissioner of sexual health services, so there's a real connection here. This really does need all joining into a coherent strategy. So Anya, I'm really delighted to hear that you are working definitely with my colleague Emma Davies, but there are other colleagues in each local public health team that I'm sure will be really interested in supporting this work from a population health point of view.
Great. Great.
Can I just very quickly say we've got a stakeholder webinar taking place next week around that as well. So.
Bushra.
I've got a number of points. Firstly, just a plea that the MDT needs to include, as well as primary and secondary care, it needs to include the community care because they often provide community gynecology. I'm a bit concerned about the idea that we're going to invest this money in more training when there is already money invested into training, particularly in things like LARC fitting, pessary fitting. That is already provided by the training hub to primary care. If there is low uptake, that is probably because at the moment, particularly LARC services are not well remunerated. So the service does not pay well enough for a GP to even think about being a coil fitter. That just does not make sense, which has a knock-on effect for retention of GPs because they have no opportunity to do something that's a little bit outside of their normal general practice. But actually, the service is so low paid, particularly in my area, that it is barely financially viable for us to have a specialist nurse fitting coils, and certainly not for her to provide the service that she wants to provide. So it does not work out financially viable for her to have a telephone consultation in which she provides the woman with all of the information that she needs to make a capacitous decision as to whether or not she goes ahead, and then have a separate face-to-face in which she fits the coil. We do that essentially at a loss. So that's a huge issue and really feels like a better place to be, perhaps investing some money to make it actually something that practices and PCNs want to offer and are able to offer. The other issue is that at the moment the LARC service is only for contraception. So GPs and practices are only able to fit Mirena coils and other hormone-containing coils for contraception. If you need a Mirena coil or some such, because you need it as your progesterone in your HRT to protect you from endometrial cancer, you cannot have that fitted by your GP or your practice or your PCN. That is a huge issue, given that we've got, rightly, lots more women seeking HRT, wanting care for their menopause, but they cannot access this incredibly important, life-saving, because it prevents cancer, element through the practice tool. It's also, we're not able to fit it for menorrhagia or for dysfunctional uterine hemorrhage, for endometriosis, significant issues that affect a lot of women who are waiting for nearly 2 years to see complex gynecology. They could have some treatment that would make their lives much, much better in the community if they could have a coil fitted for a non-contraceptive purpose. But if your husband has had the vasectomy, if you're not sexually active because of any reason, if you're in a lesbian relationship, you would not be entitled to have that done locally in your practice because you don't need it for contraceptive purposes. That is something that really needs to be addressed, and actually that would be something that would improve uptake and really benefit patients.
Yeah, that sounds really, really comprehensive and really hard to get your head round. And it sounds like it should be, this feels like important work for this particular group. So thank you, Bushra, hugely valuable. Jason.
So I suppose building on that, so I'm really, really supportive of this, and I got really excited by this until I got to 3.4, which is the women's voices and wider system change. And I just think it's maybe worth, as Anya, unpicking what feels like a very traditional model when we're talking about opportunity to be quite creative. So I don't feel this embraces the opportunity beyond Health Watch to have some conversations which are going to be quite challenging with communities. And if it is, it's not articulated well in here. There's something for me about understanding not only the people receiving services, but the barriers to people getting into services. And we know in particular from some of our more diverse communities that they're not even accessing services and are preferring to go home because they don't understand how to navigate an increasingly kind of complex system. I think this could be much more embracing the community kind of contribution, actually how communities are having these conversations already, and we don't need to kind of reinvent wheels. There's something around how we think quite creatively about how we might deliver services to communities. And there's something for me around, if one of our key challenges is working across collaboratives, developing that relationship between the voluntary sector, who is engaging on a regular basis, with primary care, there is an opportunity here to kind of really link in a positive way. I'm not sure I understand the engagement, or if it's the way it's articulated, but I thought this was going to be creative, dynamic and exciting, and I just kind of sighed at this bit.
Oh, and you're getting lots of encouraging feedback there. But right feedback. Who else? Jane, did you?
Yeah, I wanted to go. Yeah, I don't know if you were before me, Pete. Do you mind if do you want me to?
No, good.
Yeah. Okay. This is such an important area, and I think I've talked about women's health before, haven't I? And being a woman of a certain age, the menopause, Pete, I think is incredibly important. Bushra, you've raised some of the things I was going to raise around the difficulty of getting appropriate menopause care. It's broader than that. So, you know, many people, if they can afford it, are paying privately to get that appropriate care. If they can't afford it, then they're really struggling. And by really struggling, people commit suicide, don't they, through the menopause symptoms? So you can't underestimate, can you, the importance of this work. I think it's really urgent because, you know, the promotion through other campaigns, Davina would be one, wouldn't it, where highlighting the opportunity of HRT and the difference it can make means that there's a flood of people wanting that support and not being able to access that support. So I can't underestimate how important this area of work is.
Okay, interesting. I think Peter was next, then Nigel, then Emma, then Jonathan. Peter?
Hey, Chair. Given the focus, Anya, of the work, I wonder if there's a connection we can make to FGM particularly, and whether that is something which we should draw out explicitly within the programme.
Yeah, do you want to respond to that?
I'll wait for other comments, and then if I can
Nigel,
back at the end, that would be helpful. Thank you.
I was going to say, we've got to remember that there was £600,000 over 2 years for the whole population.
Yes.
And so one of the things that this will do is shine a light on the underfunding and under-resourcing or in-equipped resourcing of what Bushra has talked about.
Yeah.
It will not plug the gap.
Yeah.
So therefore, we need to think, we'll take it all on board, but then design for the future, where we need to think about the strategy document, where we're going to put our action.
Okay.
That's what it will do. It will not cover it.
No.
And we can't say it could
No.
cover it.
Okay, very good point, Nigel.
Yeah.
Emma. It segues beautifully to some of what I was going to say, and I suppose it's an example of a really tiny pot of non-recurrent money.
Yeah.
I think the point Nigel's making around shining the light is brilliant. However, the amount of time and resource and governance and process that sits behind administering a tiny pot of money, and actually what you've described, Bushra, and others, Anya, and everybody, is if this is a priority, it's really important. It needs to be part of the design for the future and seen in the context of what we're planning for the future, rather than focusing on a tiny pot of money coming down in a disjointed way.
Yeah, thank you. I think, Jonathan.
Just a comment that I'm quite shocked at what I've just heard, and I'm amazed how ignorant I was of some of these issues. And that's just reflection as a later middle-aged man. You know. But seriously, I was quite shocked at some of those stuff. That's all, just a comment. I'm sorry.
Anya.
I think Nigel articulated exactly what I was going to say, but just to add to that, that whilst we have used part of the funding to put in a team, is a very small team. So absolutely to the points that Bushra made and to Pete, you know, this agenda is absolutely enormous, but we need to start somewhere and get some stuff off the ground and do it well. And as I tried to describe earlier, put something in that is sustainable from the outset, but that we can use as a platform to build on. So we've been very cognizant of that, to not almost be over ambitious in what can be delivered, and I'm sorry, Jason, if that's come across as being a bit in the paper, but if I can just come back to that particular point, and I think what probably doesn't come through in the paper is actually the next step around the engagement, and please be assured that that next level of engagement encompasses all of that, because what we want to do is not just get a deeper level of understanding around these 3 areas, but actually is that greater level of understanding, and particularly from some of our more underserved communities, around what matters to them, as Nigel said, to inform the future strategy. And we would hope to be bringing that back to this board to make decisions around, you know, how we prioritise or not some of this in the future. So again, apologies if it didn't come across in a more exciting way. I couldn't stress how important this agenda is, and to Jonathan's point, a lot of these issues are just not known or misunderstood, and the impact that they're having on the girls, on the lives and outcomes for women and girls in our area and indeed nationally is staggering.
Thank you, Anya. Really, thank you. We're whiz through the agenda now. Item 17 of the Constitution, you're asked to review and approve the draft letter of response from us to the NHS Constitution consultation. Anything we need to add to that, Karina, or is it just a case of approving this?
No, nothing to add. In terms of that, I mean, obviously it highlights the gap that we talked about last time, which is women's health.
Okay.
So,
So collectively we approve that letter. I'm assuming everyone's read it. 18 is an update from me, really, and it's only a quick update, just to say we made a commitment at the start of this year that we would absolutely work at improving diversity at board, and we've got 2 programmes that are just starting now. The first is around recruiting our associate NEDs, and we had our first open workshop yesterday for people interested in the role. Really interesting, had 6 people in that group. We've got another one next week. We've got our recruitment process sorted out, so we should be ready to go in September or October. I kept it open, 1 associate NED or 2, not quite sure. Let's just see how the process goes, but looking good. So that's great news. And then the second thing that I've been busy doing, with Jane's help, is I can see that this board doesn't really like long-winded training. But I'm also aware that we're obliged, and rightly, we should develop our own understanding and learning around diversity, equality, diversity. So I'm currently arranging a programme of learning for us, which would only be an hour a month over, let's say, a 6 or 8 month period. So we just get little injections of learning, along perhaps with some reading, perhaps with some personal challenge work. So quite a different approach to doing that work, but doing it in a very sustained way over a longer period, rather than, I don't think I'd have a lot of success having you all in a room for 3 or 4 hours to do diversity training. So I think we've come up with something that's quite, that will be quite stimulating, interesting, and a bit different to the things you've done before. And I think that might be a better learning model for us as a board. Anyway, it's part of our grand experiment. So I'm just giving you both a heads up on that coming. That will probably again start September, October. The other thing that I've included in this pack, which is for all of your benefit, particularly if you're required to deliver a presentation to the board, and if your team members are required to deliver presentations to the board, or you're commissioning someone else to present to the board. There are some really simple guidelines here for presenting to the board. We're going to make sure it's our discipline, Emma, Mike and I, that anyone who's coming to the board receives those guidelines before they come, and that we have sight of the presentation before it begins. So we're going to get really strict around presentations to the board. So these are jolly guidance, but don't be fooled, they're serious. So we're going to aim to improve and develop the quality of presentation to the board. So I'm just including for you that guidance there for your own reference. Item 20 is returning to the board assurance framework. I'm looking to you now. Are there comments anyone wants to make about the BAF in relation to the conversation that we've had? I don't think so. Item 21, is items for information, the good news briefing, which we always enjoy, the Digital Strategy Committee terms of reference, which I think are for our information, and we have one question from the public today. The question is, I'm looking to either Jane or Teresa for response to that question. I understand one of you two has that prepared.
I do. I'm trying to find it.
Thank you, Jane.
Oh, gosh, sorry, I've got
some
papers in front of me. I don't know what I've done with it now. So the question from the public, it's about autism.
I can help you with it if you like.
Yeah,
the question is,
I've got it written down.
Autism is a neurological condition, not a medical condition. It's part of the ICS-ICB remit to address the considerable deficit of both psychosocial support and social care for autistic adults, particularly those late identified, to prevent mental and physical health problems impacting suicide prevalence and reduce life expectancy? And if so, how does we propose to achieve and fund this? Okay. So this is a question from the public.
Yeah. So in terms of that response, so the gentleman in question has met members of the local authority and also the place-based teams already. And what this does really, I suppose it talks to our changing approach to mental health services and how we're going to adopt those across the whole of the ICB. So what we've done is we're working with the Mental Health Collaborative, so they, as the paper that got approved last time, about how do we move forward on the priorities that as a generic offer across the whole of the population of the ICB, but also tailored to individual populations. So that piece of work is happening at the moment, and I'm sure if Brent was here could give you a bit more information. But specifically to that, what we've done is identify, there's 4 priorities that we've identified as part of the mental health collaborative, and that is one of the services.
Okay.
So we recognise that there are shortcomings in the service at the moment because through to increasing demand, but there's more work to be done, and that is definitely one of the priorities. So there's 4 services, which unfortunately I've got a piece of paper that describes all this and I now can't find it. But we've also got a response that we can actually, a written response from our colleagues in place.
We did say that we would produce a written response
and we have got
to
a
the
written
inquirer.
response. Yes,
okay.
we have.
Lovely. Thank you very much indeed. This is the first time we've had a question to the board, and I rather like that the public ask us questions. So thank you, Jane. There's only one matter of any other business, and that's just to remind you all that the Humber and North Yorkshire annual general meeting takes place today at 5 o'clock. I think people can log on to that live on the internet at 5. This is different to our usual AGMs. This is a totally recorded AGM. It's an AGM film rather than a live event. We think that'll improve the quality of what we do enormously for everyone, including the public. And I'd be really pleased to know any feedback anyone might have about that. So let me know.
It's by far the biggest event today.
8 o'clock viewing time. We meet next on Wednesday the 14th of August, and it's possible that we'll be meeting in our own boardroom then. It's just possible. So listen, thank you all very much indeed. You've been terrific this morning. I think we've had great quality conversation, open conversation and collegiate conversation. So thank you. Let's return at 10 to 2, please. Thank you very much indeed.